Thank you. Good morning, everybody. Welcome to ED&A. I'm opening the public hearing on House Bill 1413, and I call Representative Gregg.
Good morning, Madam Chairwoman and committee. It's nice to see you all today. For the record, I'm Representative Alicia Gregg. I represent Nashua Ward 7, and I'm here today to talk about House Bill 1413. And this is a bill that, in kind of looking at wording and how we're licensing and stuff with our different sections, we came across this particular section that has some outdated language, but not only that, it's duplicative. And so I'm going to let OLPC is here. I'm going to let them explain why it's duplicative even more. But what this does is just kind of cleans this up so it's less confusing as we go about our licensing process. And I think that she would be better qualified to explain that more.
All right, thank you. Director Courtney?
Thank you, Madam Chair, members of the committee, Lindsay Courtney, Executive Director, OPLC, and wish to thank Representative Gregg for bringing this forward. So essentially what this bill does is it would repeal the current provision in the statute that provides for, I'm going to give you the exact term, unlicensed practice under supervision agreement. So that's 330A22. So as you may recall, several years ago, this legislative body established additional license types under the Board of Mental Health Practice. Several of those license types are called the conditional licensure. And the testimony that we heard was essentially that we needed to establish licensure in order to provide an easier pathway for reimbursement. So as it stands, we currently have two pathways for these people. We have the unlicensed person who is operating under an approved supervision agreement under 330A:22. And then you have folks that are licensed, operating under supervision agreement, but are subject to the jurisdiction of the board. And this dichotomy presents some challenges, I think, administratively to the office, but also I think what we've observed is the challenge with respect to the unlicensed part is that the board doesn't have, excuse me, they don't have jurisdiction over the individuals who are actually practicing under supervision. So if there is an issue, and we've had this happen, where the person being supervised commits misconduct, the board doesn't have that jurisdiction and cannot discipline and otherwise notify the public that there could be a problem. Actually, the burden is on the licensee providing the supervision. Whereas under the other model, the person who is licensed as a conditional license is subject to the jurisdiction of the board. So essentially, this bill would repeal that second pathway and provide for one pathway to obtain your LICSW, which is a conditional license for a certain period of time under supervision that's approved by the board. Happy to answer any questions.
Thank you. I have a question. How many people have conditional licenses versus are practicing without licenses? Or don't you know the latter number?
So I don't know the total number of people who have approved supervision agreements.
Yes.
I think you may recall that the rules establishing the conditional licenses were the rules that issue that the governor and others brought forward at an executive council meeting. And JLCAR considered those rules in December, postponed them, and they will be heard by JLCAR, I think, on Friday. We've resolved the stakeholder concerns, so I have every reason to think that they will move forward. But we haven't actually issued conditional licenses. I suspect that by the time, if this legislation were to pass, a lot of people who currently have approved supervision agreements would seek conditional licenses because, again, it provides that benefit of allowing for reimbursement opportunities.
So how many people have approved supervisory agreements?
That I would have to get back to you on, Representative.
Thank you. It would be good to know. Does anyone, okay, Representative Grota and then Lakis.
Thank you. Ms. Courtney, I just want to make sure that I understand this. I'm sorry, did you say Representative Lucas?
After you.
Okay, thank you. So are we saying then there will not be a path for unlicensed people requiring supervision? Is that what we're saying?
Yes, if you were to adopt this, then correct.
Okay. Representative Lakis.
Thank you. So right now, are there any requirements for someone, for anything for the person who is going to work under the supervisory agreement? And if so, how do those compare to the requirements for someone to get a conditional license? I'm trying to figure out if there's somebody who's currently working under the such a supervisory agreement who could not apply, at least without doing something further, for a conditional license.
I think there are members of the board here, and I would defer to them on the specifics, but I think the intent when adopting or I'm sorry, working on the rules to adopting the conditional licensure, that the intent was to keep the requirements the same.
Okay, thank you.
Representative Schmidt and then Simon.
Thank you, Madam Chair. So I heard your earlier answer to Representative Lekis's question, the chair's question about the numbers. So even if you don't have the exact number at the moment and you're going to get it for us, do you have some idea whether it's a lot or a very few or what, if you have any idea?
I don't want to guess, Representative, so I can certainly email the committee that number by the end of the day today.
That would be great. Thank you.
All right. Representative Simon.
Thank you, Madam Chair, and thank you, Director, for taking my question. You had mentioned that one of the problems with the supervisory agreement is that there's no direct oversight of the board. Is that correct?
Yes.
However, looking at the statute, they do have direct supervision over the licensed practitioner who's overseeing the supervised candidate, correct?
Correct.
So I just want to make sure I understand correctly as all. So don't they technically have supervision over that person through the licensed individual?
Yes, well, so they do have jurisdiction over the licensee providing supervision. The issue is that sometimes instances of misconduct are not due to a lack of supervision or appropriate supervision. And so you can't always take action against the licensee providing supervision. And then you're left with no mechanism to notify the public that there was this finding of this issue of concern.
Thank you for that clarification. Appreciate it.
Other questions? Thank you very much.
Thank you for your time.
Melbourne Moran. There.
There we go. Hi, thank you for having me, Madam Chair. My name is Melbourne Moran Jr. I'm a licensed independent clinical social worker. I'm also a former state rep representing formerly of Ward 7, and I'm also alderman at large for New Hampshire's greatest city, the city of Nashua. But here today, I'm representing my company, Wanderlust Therapeutic Services. We provide counseling to over 1,000 individuals in southern New Hampshire, and about 30% of those individuals are Medicaid or Medicare patients. We're about a $2+ million company or so. I'm here to speak to you about this supervision contract, which is wholly unfair to the private sector of mental health counseling. And I'm glad to see that this legislation was brought forth to eliminate it. Some of you may not know, but these supervision agreements do not apply to the mental health centers or nonprofits or institutions. They're exempt from having a supervision contract. This only applies to the for-profit industry. If there is a person who has a master's degree in social work who wants to practice psychotherapy at Greater Nashua Mental Health Care, they can start on day one if they graduate from graduate school. If I want them to work for me, I have to get approval from the board through a supervision contract, because otherwise they're not permitted to conduct psychotherapy in the state of New Hampshire. That is one of the reasons I'm here to ask that you eliminate this, and as the board has already saw fit, create the conditional licensures of LICSWC, LCMHCC, So that person who's applying, exact same requirements, if you're following the rules of the Board of Mental Health, that someone would have for the supervision agreement is already in place, that they would just, whoever has it now, my understanding from reading the rules as proposed, and I believe they're going to be similar, unless there's someone else from the board here that can state more detailed facts, that those folks would just migrate to the conditional licensure and not have an interruption of the service that they're providing to their clients. One major issue with the supervision contracts as they stand, I have about 35 employees, maybe half of which are under supervision agreements and half are licensed. I have licensed providers who are in their 80s. If that person suddenly becomes ill or dies, the person that they're supervising cannot see their hundreds of patients. I'm gonna say 4 clinicians, because that's, I think the board caps at 4 supervisees per licensee. We have to stop providing treatment because they are no longer under a supervision agreement because that person's incapacitated, their supervisor. That does not apply with someone at the mental health center, someone at Harbor Care, or another nonprofit institution. And that's in one of the RSAs of 330. So I'm here to ask that you repeal this language because it's wholly unfair to small businesses that are providing mental health care. And quite frankly, now that private insurances are allowing pre-licensed professionals to bill through their licensed supervisor, it is very uncompetitive. And I cannot see anywhere in the state of New Hampshire to have a business be uncompetitive with a nonprofit. It blows my mind. And I'm a Democrat. Very funny story. My colleague from Ward 1, he's an alderman with me, Tyler Govea, Republican. He's downstairs advocating for the firefighters, and I'm up here fighting for capitalism. Very big day today. But I'm saying that these contracts are not fair to the private mental health industry. There's a mechanism coming forth to allow conditional licensures that gives board oversight of someone who's not fully licensed. And it eliminates this competitive advantage that nonprofits have against the private industry, who, in my opinion, provide better care. And I'm doing it with my money, not state money.
Okay, well, thank you. I'm glad you're in favor of capitalism. Is there anyone that has Representative Manjaputi?
Thank you, Madam Chair. So if I understand you correctly, this is creating, currently what we have in the system is 2-tier for mental health providers. Am I correct?
Yeah, there's a tier for nonprofits and a tier for the private industry. Nonprofits, folks, they can still get a contract. They don't need it. I worked in nonprofits before this. I can tell you many people did not get it. They go to try to get their license and I've been supervised for 2 years. Oh, there's no board contract on file. You can't. But why was I practicing for 2 years? Because your company's exempt. So there's also a lot of confusion around how someone can get licensed because of this contract that exists the way it is.
Follow-up, Madam Chair. Thank you. So how does this help or enhance the acute shortage we have for mental health providers in the state? And how does this allow to get more people to get into mental health field?
That's an excellent question. If this was eliminated the day after someone has conferred a graduate degree that meets the qualifications of the board to render psychotherapy while being supervised, they could do that day one instead of waiting up to, I think it's 120 days, which when I first opened my business in Nashua in 2020, my second office, I had to wait 120 days for the Board of Mental Health to approve a contract before one of my employees could start to work for me. Doesn't make sense. So
Right.
people will be able to work and provide health care. Yes.
Okay. All right. Representative Blackus?
This is for you. Is somebody from the board signed up to speak, or if not, if they could answer some questions?
Is there somebody from the Board of Mental Health Practice here? Yes. We'll talk. We'll ask you to put in a card, and we have some questions for you.
The Board of Mental Health has not had a chance to meet and vote to authorize anyone to speak. They wanted to be here for this. They cared deeply and passionately. But the Board of
Thank
Mental
you.
Health-
I understand that you haven't taken a vote and you don't have a formal support or opposed position, but you should be able to give us some information, I hope.
I can try.
Okay, thank you. Please, we would love to have that. Okay, any other questions? Seeing none, thank you for your
Thank you so much.
testimony. All right, Diane Castrucci.
Hi, my name is Diane Castrucci. I am a licensed substance use counselor, and I'm here representing myself because I'm not currently licensed by the board that this vote is about. However, I am opposed to it based on what clinical supervision is supposed to be about. So, RSA 330CA talks about the type of supervision and that it needs to be convenient between the person who's supervised and the person who is providing the supervision, and the types of protections that need to be in place for appropriate supervision. The way it's written, it's 100% aligned with the LADAC board. It is important for there to be a supervisor in place when someone is a candidate towards a credential, because the supervision that is provided is about helping that person learn how to do what they're trying to do. It helps protect the public by guiding them in appropriate ways of delivering services. It helps them deal with issues so that, like, if I'm the counselor and I'm brand new and I'm just trying to learn, I don't try to treat them like my dad, you know, because my dad needed services kind of situation. It helps them separate their own personal stuff out of the services that they're trying to provide to their client. Just as one example of a very small amount of what clinical supervision does. Clinical supervision also helps them with on-the-job training about how to be a proper counselor. And without that clinical supervision, there's just regular administrative supervision from an agency. And the clinical because of clinical supervision being set up, you're able to talk about confidential information specifically about a client in a different way than you would with a general overall administrative supervisor. That is the end of my testimony.
Thank you. Could you answer a question or two?
I can try.
Okay, I understand that you're testifying that the conditions set up for supervision here are correct, is it?
I agree with them. Yes, I
Okay.
like how they're set up. I like section 330A and how it describes clinical
Okay.
supervision. I believe you don't take away something that's not broken.
Okay, the question is, are you in support of allowing unlicensed people to enter into these agreements? Because that's what the sponsor says the difference is. And
I don't see that piece in the legislation.
okay, thank you. Representative Broda?
So in the legislation, it repeals all of RSA-A-22. So is there a part of the RSA that we could keep and eliminate some? I'm wondering if there's just perhaps a part of RSA 22 that doesn't apply.
Well,
I'm trying to, because it repeats the whole, I'm looking it up as we speak, and I looked
yeah,
at
no,
this.
I agree. Representative Broda, I think what we would want to do is, instead of saying a candidate for mental health licensure, say a person with a conditional license would be the way to do it.
Madam Chair, we don't know how many, I thought there were no conditional licenses issued at this time.
No, but they're set up in statute,
Ah,
and the rules are almost done.
Mm-hmm.
Okay. So that's the question is, are you in support of unlicensed people being supervised or just people who would be on track for the license?
I believe anyone unlicensed should be supervised. In the LADAC world, once someone has their credential, if it is a bachelor's level or below, they still need supervision. Whereas someone who is master's level or greater can work with peer collaboration with their peers. But there is still some mechanism that exists that has them communicating with each other about proper care of clients.
Thank you very much. I think
Follow up.
follow up.
Thank you. So I understand what part of 322A. So the part of 322A that says that the supervision of a candidate for mental health licensure shall include the following. So basically, it defines what that relationship is between the person doing the supervision and the person being supervised. And perhaps we may want to take a look at that because it actually formalizes that relationship and it makes it rather strict.
Mhm.
And so maybe it can be, for example, right? They have to assume the responsibility of the candidate, which you understand, right? And then if they cease to supervise that person, they need to be notified in writing. I'm just wondering if some of this should be done in rules as opposed to in statute. So does this make sense to where I'm heading? I don't know if.
Well, I think it's not as quick and easy as we thought.
Okay, well, definitely not as quick and easy as we thought. Exactly.
Okay.
Mhm.
But thank you for that information. It's very valuable. Any other questions? Okay. And ma'am from the board?
Right now, provisional licensee has the supervision set up. Correct?
You're talking about the conditional license?
Conditional, sorry.
Okay,
Yeah.
certainly. It goes in tandem with the conditional license and, sorry, I'm not able to see you, but I am still talking to you. And requires that, that the supervisor be properly vetted for supervision as well as the candidate having their goals in place for what they are hoping to get out of supervision. And then the board can make sure that those line up with their licensure, license type, and that they meet the high standard. These folks are going to be diagnosing individuals, and so this level of supervision is incredibly important.
Follow up, Madam Chair. I'm aware of clinical fellowship year in speech language pathology and audiology. So as soon as you graduate, you have to do 9 months or a year of clinical fellowship year to get your license to practice independently. Is provisional license similar to that in mental health?
It sounds analogous to me, yes. It's a 2-year requirement, however, rather than 9 months. But yes, to prepare them for diagnosing and other such.
Okay. Thank you. Other questions?
Madam Chair, is this going to go to a subcommittee?
I believe it should, yes. If it does, it's going to the licensing subcommittee.
We got to work this out.
Representative Blackus?
Thank you. So I'm looking at the statute that this would repeal about the supervision. It says the supervision of a candidate for mental health licensure. My question is, what are the requirements to be a candidate for mental health licensure?
I was just glancing at that and I don't see any.
I mean, is
Perhaps
it
there
elsewhere
are
in
some.
statute maybe or rules or?
That's a great question. I am looking at the definitions, and in the statute, there's not a definition for candidate for mental health licensure. I had that same question with the board when I first joined them. I would recommend that they define it, and maybe they have in rule, and I could look that up for you.
Follow up?
Follow up, yes.
Okay, so I guess this is going to the licensing subcommittee. If you could be available, or someone else who could answer these questions could be available. What I'm trying to get at is, you know, what does it take to be a candidate for mental health licensure, and how does that compare to someone who's eligible to apply for a conditional license? I'm trying to see if, in effect, this is a direct replacement, except for the board having authority and not having to have a supervisory agreement, or will there be a supervisory agreement for conditional license? Those are the kind of questions I hope someone can answer for the subcommittee.
Sure. Well, the first thing is that the candidate for mental health licensure is for one license type for the licensed clinical mental health counselor, whereas the conditional license is for all of the license types. It's not just for mental health counselors, but for social license to practice independently, but they are working towards licensure, and so they must have supervision when they're not properly licensed.
Thank you, Madam Chair.
Okay. Anyone?
Madam Chair?
Yes,
I
sir.
see the
Ma'am,
prime
sir.
sponsor eager to get back and clarify something. Is
Yes,
that the
thank you.
proper-
Thank you, and I'm glad you will have your support for the subcommittee. Representative Gregg, you have some more information for us?
Thank you, Madam Chairman, Chairwoman and committee. I should have had more faith in myself on my first bill to explain this a little bit better, and now learning curves. So thank you for giving me this opportunity once again. I'm Representative Alicia Gregg. I represent Nashua Ward 7. So in looking at this, my initial conversation was actually around the language which specifies and legal. So it talks about how the supervisor must be both professionally and legally responsible for their candidate, which is interesting if you say and legally responsible within the workplace. This particular language just says and legally responsible. I mean, it's hard enough if you have an over 18-year-old in your house to stay legally responsible for that person. So you think about this and how this complicates somebody wanting to be a supervisor knowing this. So in looking at this statute, this was actually pretty common language back in the early 1980s. When they had this as far as social work goes, they have this and legal was in there. If you look at the history of this, it slowly fades off. Other statutes have replaced those particular licensure statutes. This one stayed. So when I called OPLC and said, would you be in favor of taking off and legal? Because they actually said it was duplicative, and that was the biggest problem. Now, what is it duplicative of? And they stated that it was duplicative of 330A, 18D. So at that point, I looked at that and I said, well, that's social work. So a conditional license for social work. So, I kind of saw, okay, I can see where part of this is duplicative because it's all kind of integrated. But then I think what we're doing is this also refers back to 330A, which is mental health practice section. So by repealing this particular statute that has an older language that's not used in many other cases anymore, what we're doing is we're going to leave the regulation. We're not saying nobody should be supervised, but we're going to leave the regulation of the supervision agreement to the board, which is kicking back to 330A. So I actually have printouts of each of these if you guys would like to have them tangible and kind of look at them side by side. That always helps me. But it's not that we're wanting to get away with this big super. It's that we're saying this particular, because of the older language, because it's duplicative, it actually works against, being able to provide supervisors that clear cut what's going to happen when they are. So.
Thank you.
You're welcome.
This will be going to subcommittee to
Yeah.
sweat the details.
Great.
So if you could give those papers
Yeah.
to Representative Lekes.
I
who's
absolutely
the
will.
chair of
Thank you
this-
so much
of
for the extra
subcommittee.
time. I appreciate it.
All right. Any other questions? All right. Is there anyone else who wishes to testify on House Bill 1413? All right, seeing none, I will close the public hearing. We will open the hearing at next hearing at 10:45. Well, it sounds like there's like that exemption for nonprofits. I don't see that anywhere.
Well, if there is an exemption for nonprofit, that makes no sense whatsoever. You either need it or you don't.
Right. Welcome back. Representative Rochford.
Thank you, Madam Chair. Members of the committee, I appreciate the time you've given me today to introduce HB 1112. This is, I sent around some testimony last night via email that you should have received, and I submitted a printed copy to the clerk. But this bill is, many bills we see here, we vote on and even introduce that really don't have a whole lot of impact on ourselves individually. HB 1112 does have an impact on myself. If passed and implemented, I will fully be expected to comply with this, as I'm a licensed pharmacist in the state of New Hampshire, currently on the Board of Pharmacy, and the Board of Pharmacy is under the rule, as you know, is OPLC. 1112 really I started opening my eyes onto the idea of human trafficking in 2016, and that really started back in 2007 when I went on a mission trip in southern Mexico, and it was a remote town, literally in the middle of nowhere. We were going into villages that were on dirt roads that were, never seen a whole lot of traffic. We delivered healthcare and medical services to these folks. I went back in 2016, and what had happened from 2007 to 2016 was dramatic. These little towns, now the little roads, were caravans were passing in front of these houses. People from clearly all over the world were headed north with a lot of possessions. Many of them didn't speak. None of them spoke English. Most of them didn't speak even Spanish, and certainly not the local dialect that we were in. So we had an opportunity to visually see what was happening, going on down there. As we have seen over the last 3 or 4 years, that is massively exploded to something that we can't even comprehend. Even north of the Notches, where I'm from, I grew up in Coos County. The Canadian border was always in our backyard. And even now, we're seeing crossings that we've never seen before. My neighbor in Littleton is a Border Patrol agent. He says every day they're getting people that are migrating. And we all know why they're migrating. For the most part, they're coming here because the United States is the best country in the world. We have freedoms here that are unseen in other parts of the world, opportunities that are unseen in other parts of the world. But we wonder, when we see all these people, how many are coming here against their will, or how many people signed up for something that they thought they were getting, only to realize that they were being shuffled, moved, purchased, trafficked. And that's really where this is about. HB 1112 is about human trafficking. And it's about the fact that there are people in this country, in this state, that are here against their will, that are here because they didn't understand what they signed up for. They're here for profit, for gratification, for whatever it is. But I ask you, members of the committee here, how many of you have ever been to a pharmacy? How many have ever been to a physician's office? How many have ever been to an emergency room? The reality is, people will go to seek medical care, whether they're here legally or whether they're here undocumented. And the purpose of the HB 1112 is just an opportunity for education of our healthcare providers. Our healthcare providers in our communities and our states, whether it be physicians, nurses, pharmacists, dentists, we will come in contact with people that are trafficked. And HB 1112, one of the things it does not do, it doesn't add any additional education to these folks. It doesn't add any additional charges, fees, price, costs to the licensed professionals in the state. But what it does do, it allows OPLC, as a part of the annual continuing education, actually it's biannual now, continuing education process of their required credits that they have to receive, which we all do. 1 hour of that biannual education has to be in human trafficking. And the idea is really based on a program that came out of Florida. And Florida, when we renew our licenses down in Florida, we take an hour of human trafficking education. It just talks about awareness, education, what to do about it, how to recognize it, and if suspected, who to report it to. I've included all kinds of data and dialogue and statistics in the package here, and you're welcome to look at it. But one of the things that I just want to emphasize is that this is not new. This concept of awareness to certain topics is not new, especially human trafficking. According to the University of Michigan, Connecticut, Florida, Louisiana, Michigan, New Jersey, New York, Ohio, Texas, and Washington have requirements for their healthcare providers to be educated on human trafficking. Some of those states are southern states, some of them are northern states, some of them are places where we wouldn't expect it. But the reality is that it's here. There's United States Department of Health and Human Services has a human trafficking hotline. And since its inception, it's received 571 signals, if you will, in a variety of formats. So that's hotline calls, text messages, online reports, whatnot. And in those 571 signals, the human trafficking hotline has identified 112 cases of human trafficking. 366 were identified. That's right here in New Hampshire. So sobering when you think about this as an underground activity. This is an activity that people don't talk about. It's secret. It's the people are silenced when they talk about it. So just in New Hampshire, 366 victims of an intentionally silenced practice are going on right here. I think when I decided to submit this bill, really what like I said, I've thought about it and began to comprehend it and really start thinking about how much is out there that we don't see. When have we gone to a restaurant and had that whole staff turnover with new people? And I know that I've been to several of them, and overnight, what's the story behind that? It could be innocuous, it might not be. But the issue that kind of drove it home for me was over the summer when we had a New Hampshire nurse who was working in Haiti as a missionary, and she was kidnapped. And many people speculate that she was kidnapped for the purpose of human trafficking. And I think that to pretend that it's not here is short-sighted. This is a bill that it targets the individuals in the state that will have a high touch with this. And again, it's not adding any additional education requirements or fees that they have to pay. It's part of the normal process of recredentialing in the state of New Hampshire. I'm going to leave it here with you, and I'm happy to answer questions. I do have to know I'm literally currently presiding over a Board of Pharmacy meeting across the street, so I'm happy to take a couple of questions, and I've got to get back to my meeting.
Representative Lekis does have a question.
Sure.
Thank you. I'm just trying to reconcile, what I heard you say and what's in the bill. And
Yeah.
you said that there's something about 1 hour. You said there was no additional training requirements and no additional cost, but this thing requires at least 2 hours of continuing education in this area, so that doesn't seem to jive. And that's got to be paid for somehow.
Yeah.
I mean, there's going to be maybe some change the cost of that or something. So I don't understand your testimony.
Sure, absolutely. So every health professional in New Hampshire has to, in order as a part of recredentialing every year, has to do a certain number of hours every 2 years. In my case, as a pharmacist, I have to do 30 hours of continuing education every other year to continue to get my license. So this is not adding an additional 2 hours, but of those 30 hours, of the hours that professionals are required to do in order to get their license, 2 of them per biennium, 1 per year, has to be in this topic. And it's not an additional fee in that they're going to have to they're paying for these hours anyway. If we don't have this bill, they're not paying anything additional. They're going to be paying, if we don't have this, they'll pay for something else. So it's not adding any additional burden on the, as far as a cost or hour requirement.
Follow up?
Follow up.
Well, presumably, in the case of pharmacists, the 30 hours was hopefully being consumed teaching something of some value. So you're going to take 2 hours away from that for this, and what's going to be lost as part of that? I have to wonder.
Yeah, I mean, 30 hours is a lot of hours. I mean, just in again, speaking from personal experience, if you're going through the motions, if you will, if you're attending professional continuing education in the normal course of your career, you're going to get far more than that. Already, at the end of last year, I'm already ahead of what I personally would normally get. And there's no specification on what those, as it is now, there's no specifications of what those hours could be. So conceivably, if you found 30 hours of HIV counseling, which is good, right? I mean, I'm not going to say, but you could load up your entire 30 hours with something that may or may not be, pertaining to your specialty.
All right, thank you.
Yeah.
All right, thank you. Representative Broda?
Yes, I think this might help because I'm a little bit confused. In your continuing hours, is it not part of the your rules for licensure that the 30 hours are cover these specific subjects, or is it you have like a menu and you can pick 2 from A and 3 from B? Is this? Can you help us on that?
Absolutely. So when a board defines what the hours have to be in. So for instance, I can speak for myself. My daughter's a nurse. I can speak for her. My brother's a dentist. We can, what the rules say is they have to, specifically for doing, I'm going to give you an example in pharmacy. They have to be, pharmacy uses ACPE approved credit hours. So ACP is the National Credentialing Agency for crediting. So if I want to put a course on, I want people to be able to get credit for it, I have to run it through this ACPE. So they have to be 15 hours, 30 hours every other year, ACPE approved credit hours. So that could be in anything. I mean, it's if when I get my license and I have to renew it, I could get, when you go, I mean, the providers of ACPE credit hours are wide and they're varied. I mean, literally hundreds, if not thousands of courses that you can take that are ACP accredited. And I can find those courses and there are many, because so many states are doing this, there are a lot of ACPE accredited courses in human trafficking. So it's not going to be hard to find one of these courses for those folks.
Okay, that was my follow-up question. So thanks so much.
Yeah, and I'm going to add, if we were the trailblazers in this, if we were the first ones out of the gate, then that would, quite frankly, probably impose a hardship. But because there are so many other states doing it, there are many of the credit providers are providing credits geared towards this requirement.
Representative Schuett?
Thank you, Madam Chair. That basically answered my question, if there were people provided to do the education.
Okay. Other questions? Representative Simon?
Thank you, Madam Chair. I know you're in a hurry.
No.
You've mentioned that several other states have already implemented this. Are there measurable successes that you can report in that area that you know of where implementing it has helped to pinpoint trafficking?
Yeah, first, there's 2 answers. I'm going to answer that in 2 ways. One, it's fairly new in that only within the last 5 or 6 years that we've seen this implementation of that. I think if there was probably a state that could quantify it, and I don't have those numbers in front of me, and I'm surmising that Florida has really been out front with a lot of this. And in fact, I believe there's a conference just this afternoon at the Holiday Inn talking about a Florida-based human trafficking program that is geared towards the hotel industry. I don't have numbers that I can put on hand. I would speculate if there are, it would be either the University of Michigan or the state of Florida that would have those.
Thank you.
Yep.
Other questions? Representative Benjaputi?
Thank you, Madam Chair. A quick one. Are you, through this bill, are you putting it such that just like the abuse and neglect are to be reported, this also has to be a reporting event for any pharmacist?
Yes, thank you for the question. And this is just an education component of this bill. This is when I put this together, I met with the director of OPLC and I asked how we could do this, and she suggested this would be the format that we would go. But it's just the education. I don't want to deputize every healthcare provider and mandate that you get into adding that, because I think that opens a can of worms. But it's the idea of recognizing it and understanding, if you see it, this is how you would be it. This bill does not have a requirement for reporting, but it certainly, having gone through a lot of these trainings, there is they often do detail on how you would report something like this. But there is no duty to report in this bill.
Thank you. Okay. Thank you very much for your testimony. Good luck with your board.
Great, thank you.
Ben Bradley?
Chair, while he's getting ready, he referenced some information packet that he had provided.
It was emailed. And here are some hard copies if you want one. And there's one hard copy here for the file.
No, but it's on the email.
Morning, Madam Chair. Members of the committee, my name is Ben Bradley. I'm the Vice President, State Government Relations with the New Hampshire Hospital Association, representing all 26 of New Hampshire's hospitals, as well as all specialty hospitals throughout New Hampshire. While we appreciate the focus of HB 1112 and the importance of training in human trafficking, each professional board that regulates health professionals already has the statutory authority to require specific training as they see fit. Although there may be other worthy training topics for health professionals on topics such as reporting of elderly abuse or communicable disease, this would be the only education requirement mandated by the legislature. Historically, except for opioid prescribing training requirements that were repealed last year, the legislature has left decisions about mandated training to the professional boards with oversight of health professionals. We believe these decisions are best suited for each professional board to determine, and therefore the Hospital Association is respectfully unable to support this bill. Thank you for the opportunity to provide our comments, and I'm happy to take your questions.
Thank you. Representative Gould.
Thank you, Madam Chair, and thank you for taking my question. My question is, do you think this is a topic that the boards are aware enough of to even be on their radar?
I haven't solicited each board, but you did just hear from a member of the pharmacy board, so it's attuned to him. And so I can't comment on everybody, but I would suggest that they review the training of their licensees routinely.
Representative Leckis.
Thank you. I can't comment on pharmacies, but I can't remember being in any medical facility that doesn't have some notices up about reporting if you feel threatened at home or other things like that. So my question is, along with that, are hospitals and other medical facilities doing some, what if any training goes along with those notices for the staff already?
Certainly. I think hospitals take this issue very seriously. Again, I haven't solicited all our hospitals to find out what kind of training they provide in human trafficking. I'm really just hoping to speak to the bill and what it does, which is would have the legislature mandate specific training on human trafficking. I'm happy to get additional information for you. But we do take this issue very seriously, just respectfully believe that it should be at the board level for determining what should be required.
Follow up. Yeah, I'd appreciate if you could do it, and that, it does apply to the bill, because if, you know, if there is something going on already about this, I'm not sure that requiring some of the currently existed training would be the best way to go.
Understood.
Okay. Representative Schmidt?
Thank you, Madam Chair. Are you still working with Wentworth Douglas as you have in the past, or are you now just with New Hampshire Hospital Association?
So I'm employed by the New Hampshire Hospital Association, and Wentworth Douglas Hospital is a member of our association.
Yeah, okay, thank you.
Other questions? Thank you for your testimony.
Thank you, Madam Chair.
Diane Castrucci?
Hi, my name is Diane Castrucci. I am the Executive Director of the New Hampshire Alcohol and Drug Abuse Counselors Association, which runs the New Hampshire Training Institute on Addictive Disorders. We are the largest, through state contracts, funded to provide professional development training for people who work in mental health and substance use. I would be opposed to this bill because when you have a requirement that people have to do every 2 years, it tends to be something that is broad-based, like the ones that we currently have, which are ethics. People are required to get ethics every 2 years. They're supposed to get suicide prevention training every 2 years. The increase of suicide training was done through a legislative process. So there is a precedent out there to create training imposed by the legislature, because that's how several boards incorporated the suicide prevention. The topic of human trafficking, we have offered at the Training Institute off and on at least 6 years. And when the state got funding for a state opioid response, the SOAR funding, a lot of human trafficking was happening related to opiates, that people that were being trafficked would be forced to become addicted to opiates so that they could be managed and controlled by the opiate. So you had to do certain things, and then you would get your fix, and then, you know, so there was a lot of human trafficking happening. So the mental health and substance use provider communities have been getting training in human trafficking for a while. I could see it as a valuable thing for initial licensure so that people start off knowing about it, but as a requirement to get more training about it every 2 years, it runs into a problem where it's the same training every time, so that there are less trainings available for people to go to. I'm not aware of it being offered, a lot in other states. New Hampshire is stronger when it comes to the professional development education than Maine or Vermont. Massachusetts, very strong. But in terms of the number of trainings provided, it would be difficult. If it is mandated for mental health providers, then it's logical to think that the state would support workforce development, and they would need to provide funding for that type of education, especially if it's being offered at the level that it would take to reach all of the providers, which would be several a year. So although it's not a direct cost, there would definitely be an indirect cost. Providers, we do have to get substance use education. Education for renewal. in the mental health substance use space, it's 40 to 48 hours a year. And Representative Lycus is correct that if we are doing the human trafficking education, chances are something else is not going to be what we're going to get the education in. So I would say yes, that human trafficking education is important. With the way things are happening with so many people coming into the country undocumented, that chances are there's a lot more human trafficking than we have any concept of. And I think it's an important thing to have. I'm just not sure that 2 hours every 2 years for every healthcare provider is the way to do it.
Thank you for your testimony. Are there any questions? Representative Gould.
Thank you, Madam Chair, and thank you for taking my question, and sorry to ask so many questions today. My question is, I like what you said about a requirement for licensing initially upfront as opposed to the ongoing requirement. Do you think that's something that can be done through licensing rather than through legislative action?
I think it can absolutely be done through administrative rule. The value when you do something through licensure versus through administrative rule is that licensure can make it happen faster. And so I guess that's a decision that needs to be made at a different level. For I think now that OPLC manages so much more of what the boards are doing, that it'll be easier to change rule and have it broadly applied, so that the changes that were made in the last legislative session could actually benefit making this happen at a different rate than what it would have if those things didn't happen.
Thank you.
Okay. Representative Schuett? Okay, fair enough. Other questions? Thank you very much for your testimony.
Thank you.
Douglas Osterhout?
Good morning, Douglas Osterhout of the OPLC. I don't have, the office doesn't take a position on this. I really came up because I have more clarifying questions. I think there's some ambiguity around some of the language. I think first off, one of those is whether the 2 hours is part of, say, a 30-hour requirement or if that's above and beyond. I'm not sure it's clear from this language. And then the second piece I have a question about is the definition of audit. If that is a separate process or if that's just part of the renewal process. If it's part of the renewal process, just making a requirement would make this audit language somewhat redundant. And then based on the testimony I just heard, I do want to clarify that OPLC would not be able to mandate that the boards undergo this in rule. The boards would still be able to set their own criteria for licensure. So to your question, Representative, if you wanted to apply to all the boards, legislation may be proper. If you wanted to give the boards the ability to choose, rule may be the appropriate route, but that's more just technical.
Okay.
And that's all I wanted to say today.
All right, we do have a question. Representative Schuett?
Thank you, Madam Chair. I will ask my question now. I was looking at this and considering if OPLC thinks the boards would be amenable to just changing the language to say that there should be an update of continuing education on this topic.
I'm not sure I could answer that question without talking to the boards first, because I can't speak on behalf of the different professional boards.
It would probably also vary from one board to the next. Yes, Representative Mangiaputi?
Thank you, Madam Chair. Do you know of any boards under OPLC that has this requirement education of identifying human trafficking as we speak today?
I'm going to say no, but there's also 57 separate boards, and I'm not necessarily familiar with the individual education requirements within the particular boards.
I'm interested in your comment on the audit because Representative Burford did not mention that. And I don't know what shall audit compliance. Does that mean 1%, 10%, 50%?
Well, I think that's my question here as well. And then also, to that point, if you make it part of the CE renewal process, we'll always check 2 hours of continuing education. I'm not sure there would need to be a separate audit. It would just be part of the renewal process.
Okay, but it doesn't define, do you currently audit continuing education? And if so, how? It varies?
It varies.
Thank you. I'm not surprised. All right. Any other questions? Representative Blackus.
One more question on that. So, when you say you check on it, and I know it varies, but I mean, is there a tendency just to verify that they filed the paperwork that they say they had the class? Or do you somehow go back to whoever offered the class, make sure they were really there or something like that?
It does vary. I mean, there are certain things you can do. You can upload continuing education certificates. There's certain reporting requirements, but it does vary from board to board. And there are some boards, I can't think of them off the top of my head because I'm not involved in the audit side, but that do require certain mandates every now and then, a little deeper dive for the continuing education component.
Okay.
Follow up?
Yeah, follow up. Yeah, I mean, I wasn't sure what that meant, and I guess it gives 541A rulemaking, so you'd have to, if this passed, you'd have to go through that process to define just what an audit meant, I suppose. But it's not specified here. Is that
Correct.
the case?
I think so.
All right, thank you.
Representative Grota?
I just want to help with this bill. Mr. Osterhout, you might remember, and correct me if I'm wrong, that we moved the responsibility of monitoring the continuing education process from the Board of Medicine to OPLC. And we had to have a small amendment at the end of we all might remember this, at the end of the January 4th or 3rd, I can't remember, House session, where we had to have an amendment removing the responsibility of that auditing from the Board of Medicine. So that's an example of an audit of is that right?
Yes, it would be an example.
Okay. Any other questions? All right. Thank you very much for your testimony. Does anyone else wish to testify on House Bill 1112? Okay. In that case, I'm closing the public hearing, and we have 10 minutes before the next on House Bill 1410. Morning. Welcome back. I'm opening the hearing on House Bill 1410, and I call in the absence of the prime sponsor, I call Representative Leckis.
Thank you, Madam Chair. Little history on this. This was among a number of bills that were requested by the governor. It was put together, as were the others, in consultation with Executive Director Courtney of OPLC, and I was asked to run it through the process. Executive Director Courtney had assured me she'd be here for this hearing. I'm not seeing her. So I can go give a quick overview on this, but I'm not prepared to go through all the details at this time. I'll skip actually part one and I'll go through the other ones first. A lot of this is similar things that we've done with, with other licensing boards, especially last year. The part two on the Nurse Practice Act, Board of Nursing, a good part of this is changing the membership of the nursing board. The number of members, who's on it, it adds, APRNs or RNs instead of just RNs in a number of places. And there's changes to the requirements for being on the board here, similar to what was done for other boards. Some language changes. The third section, which starts on page 2, line 23, gets into the powers and duties of the board. And again, this is largely going along with the changes we've had of moving certain responsibilities from the boards to OPLC. I think that's pretty much what's in that one. Okay. And similarly, on part 4 on page 3, it makes some changes to the rulemaking authority, and it moves some of it from the board to OPLC because responsibility for some issuing licenses and other things were moved as well. So all of that is pretty similar to what we've been doing. Similarly, part 5 related to criminal background checks follows, other changes we made. And part 6 changes the LNA from being licensed to registration. And part 7 makes some other changes to the nursing license. What I'd like to do, there's 2 other people here who can get into the well, first of all, get into the more of the reasons behind this, and that's Ms. Jurius, if she could speak on that, and then Director Courtney for the details of the bill from OPLC, and that's all I have.
Thank you. Ms. Jurius, if you could speak on the policy intention of this bill.
Yes, thank you, Madam Chair, and good morning, everybody. For the record, Deanna Juris from the Governor's Office, Governor Sununu's Policy Director. So the intention behind this bill, you'll be seeing a few before you. I believe, I think a number of them might be going to subcommittee. I may have heard from the chair. Similar to
This bill is in fact going to subcommittee.
Okay, great. So I'll be happy to be here to be a resource for that as well. This is a continuation of a lot of the policy initiatives that we kind of started last year. As you'll recall, there was a hefty chunk of the budget with the governor's proposal that was regulatory reform specific to licensing boards. So this is along the same lines of that idea, which is trying to consolidate boards where appropriate, to right size them to ensure that regulation is still appropriate with the Board of Nursing, but getting the membership to a more manageable amount while still making sure that appropriate parties are represented. Additionally, some of the repeals would be for additional burdensome red tape or fees for licensees or people who are working in the state to try to reduce barriers to entering the workforce or continuing in that regard. So specifically, I know the LNA license is a hot topic, and I'm sure something we will continue to discuss. But part of the consideration is there's already a federal requirement that they are on a registry that's maintained. And the condition for licensure is that they complete the coursework to be on that registry and then pay the state a fee to do their job. And so our thought is, could we eliminate that extra fee and just allow them to work without that? And there's still the oversight from the federal registry. So that would be the policy consideration there. I'm happy to answer any other specifics, but does that give you a good sense of where we're coming from?
Representative Broda?
Thank you, Ms. Jurish. Most of these, the components of this bill were in House Bill 2, correct?
I believe that is the case. And if I may, I'll just add, I think some of the cleanup language, some of the strike through in this is a result of when there was reconciling. As we know, there were a number of different bills, and I think as they were signed, effective dates were different. There might have been some language that was removed, reinserted, that this committee would have passed. So I believe some of it, the bulk of the text, is kind of cleanup from that piece of it when you were clarifying the results from the 2022 330 study committee, which the bill from 23, the number is escaping me at this point, but I think a lot of those changes kind of were reverted back. So this is kind of writing that piece of it.
Follow up. So last year in House Bill 655,
Yes.
which was also included in House Bill 2, we considered that bill and made a lot of changes to OPLC based on that. What information do you have, if any, that those changes have come to fruition and there's been a benefit seen?
I'm happy to answer that. In part, I would defer. I believe you'll hear from Executive Director Courtney. She could speak to specifics about the pace at which they are able to award the licenses due to the transfer of that authority. I don't have those figures in front of me, but I do know that the turnaround time for licensing those specific professions has been cut down drastically. So between the completion of application and the awarding of the license has been much quicker. I think the rollout for other things such as disciplinary actions where they can investigate immediately, that timeline I think will need to be played out over a longer course. I'm not sure we've seen direct results, but again, I'll defer to her on those specific metrics.
Thank you.
Yep.
Other questions? Thank you very much. And I trust you'll be able to support the subcommittee.
Happy to.
Okay. I think I will ask Director Courtney to give us some details so we know what questions to ask.
Thank you, Madam Chair. Lindsay Courtney, Executive Director, Office of Professional Licensure and Certification. And please accept my apologies for the delay in my arrival. I was with the Senate testifying on another matter. So essentially, I just wanted to explain what this bill does practically and how we would administer this bill if it were passed. So two things are easy to explain. It would essentially eliminate the requirement to register medical technicians and the requirement to license medical imaging and radiation technologists, which is not an actual license type. So you should know that there are a number, over 10 modalities that have their separate license types, but it's essentially all of the imaging licenses that fall under the advisory board for that jurisdiction. So then with respect to LNAs, what this does is it eliminates the licensure component for the licensed nursing assistants while allowing those individuals to retain the title. So essentially providing title protection. And I wanted to explain how that works practically with the office right now. So there is a federal requirement in the CFRs that all states have a mechanism to approve programs that will educate individuals. They use the term nurse aide, but other states use certified nursing assistants, licensed nursing assistants, that we educate with a certain minimum number of hours. In the federal regulations, I believe it's 75. We require 100. And that as soon as, and that they pass a competency evaluation. And it requires that as soon as the person completes that process, that we automatically register them with the state within 30 days. And what this means is there's no application process. And because the state, primarily Department of Health and Human Services, receives money from the federal government for maintaining this registry, we are not allowed to charge people to be on the registry. We also have a licensure component, which comes into place after somebody is registered. So the way it works is you complete the course, you take your competency evaluation, we get the information from the testing facility, we put the applicant into our licensing system, and it's called not licensed registry only. And then at some point, if they choose to do so, they apply with their office. They pay a $35 licensure fee. They pay a $28 fee toward the professionals health program. They undergo a criminal history records check, and we issue a license. 2 years later, they have to, they're required registry, and then 2 years from the date of their license, renew their license. I will say that it is somewhat confusing for applicants, this duplicative process. But I also wanted to point out the key differences between our current process and what is proposed. So the differences are that under what is proposed in the bill, the LNAs would not be required to undergo a criminal history records check by the office. There are some requirements for long-term care facilities and for hospitals that require criminal history records checks, but that would be conducted by the employer and it would not be conducted by the licensing authority. So that's a key difference. The other key difference is that under the federal regulations, the employer is required to provide attribute expenses for licensing LNAs to the registry as opposed to the license. And we get a de minimis amount from DHHS, and I think that they would be required to give us substantially more under the bill as proposed. But again, that's just a selfish ask from the office, not speaking to the policy considerations. So those are the primary differences. I'd be happy to answer any questions that you may have.
I have one question. From a study committee I was on some years ago, the scope of practice for an LNA primarily on nursing homes rather than hospitals and other places that LNAs work in New Hampshire.
Yeah, so I will say that the authority that the federal government has to impose licensure requirements, and we are always, I say we, OPLC in particular is always protective of the state's authority to regulate occupations as opposed to the federal government. But the federal government's authority to impose this, these registration requirements has to do with our acceptance of their funding. And I mean, DHHS's acceptance of their funding, the state's acceptance of the funding. And so it certainly comes through the long-term care process and our regulation of long-term care facilities. That said, when you look at the federal registry requirements, we are required to register anybody who has completed this course. It doesn't even matter if they work in long-term care. It doesn't matter if they work, period. The fact that they are eligible and they completed this course, we are required to register them. And so by virtue of that, it applies to everyone.
Thank you. Does anyone, yes, Representative Gould and then Manchaputi.
Thank you, Madam Chair, and thank you, Director, for taking my question. My question is, and you may or may not be able to answer that, and there may be other people here who can answer, just let me know. My question is, I'm concerned about the criminal background checks and the lack thereof, that this could, you know, are we creating a hole that people could slip through? And so my specific question is around home health care. Do you know if the background checks are done by requirement by those agencies?
I don't know. I also don't know that everybody providing home health care is an LNA, and I do think that that's an element that's a potential issue. but I don't know for certain. I would say that DHHS has imposed on the individuals that they, or I'm sorry, on the facilities they regulate, there are certain requirements for criminal history records checks. I would also say that the accrediting bodies, typically, which are private, typically do have certain requirements, but the standards for vetting them are unique.
Thank
Nicely
you.
put. Thank you. Representative Benjaputi.
Thank you, Madam Chair. Thank you for taking my question. So from the cost shifting perspective, this bill would shift the cost from the licensee to the agency or DHHS or other bigger organizations, especially with the LNA. Am I correct?
Yes, you're correct. And so right now, the Board of Nursing is not meeting its expenses in large part because we charge LNAs so little, $35, when the average cost of a license is over $150. And obviously that's because there's a capacity concern there. And so certainly that would shift the cost. Another way to resolve the issue is to just not charge a fee for LNAs. I know in the past the board hasn't supported that, but that's another way to address that issue.
Thank you. Representative Grota.
Thank you. Your question, your comment about the Board of Nursing not meeting its expenses, what does that mean? Because do you not have were you not granted a $5 million holdover so that the money that you have in extra could be used to?
Yeah, so I think those are two different issues. So every board is required to cover their 100% of their expenses. And I think, Representative, you may recall that the OPLC has had rulemaking authority regarding fees for a long time, but there have been conflicts in the law that have really precluded us from moving that forward. Both statutory and regulatory. We've recently eliminated those conflicts. But for years, the established fees, you had some boards that were bringing in, 200%, and then other boards that were bringing in 40%. And so, yes, we had a lapse, but I would say it's not because we had a lapse because certain boards were bringing in way more than they should, and it was essentially an unconstitutional tax. So we have enough funding to operate the office, but what I'm saying is not all boards are meeting their 100% of their expenses. And for the board, it's been a really big challenge because you can't raise LNA fees to $150. You just can't do it. They don't get paid enough. And so the board has opted to have their license fees structured in a way that the RNs and APRNs are essentially subsidizing the LNAs, but it's still not sufficient, taking into consideration inflation and everything else.
Follow
up.
So you run the boards as a cost center?
Do I run the boards? No, it's statutory, Representative, that we are required that the boards fully cover their costs. If, I think there's an opportunity for the legislature to consider from a policy standpoint whether they do want subsidization. I would think that would have to come from the general fund and not from other boards, because you get into the issue of taxing other licensed professionals. But this was a statutory scheme created by the legislature, not the office.
Apologies, I meant OPLC, not you personally. Thank you.
I understand.
Yes. Yes, in the OPLC reports for the last several years, you can see that some boards are overcharged and some are undercharged.
And I will say we had a budget. I'm sorry, Representative. We had a budget information session with the boards. I think it was last night. I can't even recall. Maybe the night before. In preparation for FY26 and 27. And we are going to work in tandem with them on the budget, as well as adopting new rules regarding fees to really level set. But these are some really tough conversations that we have to have, particularly for the licensed professions that don't earn enough.
Thank you. Other questions? Representative Brown?
Thank you, Madam Chair. Good morning, Director. Thanks for taking my question.
Good morning, Representative.
Can you, for me, put in a simple framework why this is necessary? Following up kind of on the governor's representative.
So I can't speak to the governor's initiative, but what I can say is practically on the LNA piece, it definitely would reduce administrative burden. It would streamline the licensure process. If it were me, I would say to the feds, you need to update your regs because they haven't been updated since the 70s, and I think that's part of the problem. But I think the process is somewhat cumbersome for those people trying to navigate. That said, and you'll grapple with this, there's certainly some policy considerations as I've outlined for you to consider. And then on the other piece, I think it's certainly just an extension of some of the efforts last session, which were intended to look at the board's, the licensed professions that may not be necessary to protect the public if there's another means of doing so.
The question, Representative Simon.
Thank you, Madam Chair. Thank you, Director, for taking my question. Still just trying to make sure that I have all of my information correct on the nursing board covering its own expenses. So if we were not to do the proposal before us, we have a shortfall of essentially $115 per LNA from the nursing board. Presently, you're saying you're stopgapping that by overcharging RNAs and other professionals to kind of balance it, which doesn't seem correct either. So if we don't do something like this, aren't we basically putting LNAs in the position of having to, statutorily speaking, if we're going to do it correctly, they should be paying $150, which doesn't seem fair in its own right, but am I correct in that?
Yes, I think and I haven't thought this fully through, but I think if this were not to pass, my recommendation to the board would be to fully eliminate the fee altogether so we could have a better sense of what it costs in order to maintain, and basically merge the two, and what it costs to maintain an LNA license and a registration, and I would try to bill HHS to recoup some of those costs. I don't know how successful that would be, but my position is that essentially we are not getting the funding that is owed to us.
Follow up?
Mm-hmm.
So you had also mentioned that the funding that could potentially come from the federal side of things, if we were to change, would be significant. What would that look like? Do you have any idea what additional funding would come from the federal government?
So if you think about the fact that the average cost overhead of a licensee is about $150, it's probably gone up since the last time I analyzed that. In my opinion, if you have 10,000 LNAs, they should be paying that full cost. Now, I don't know how much DHHS is recovering from CMS, but I suspect that it's probably sufficient to cover that. But I don't know what that looks like.
Okay, thank you.
Okay. Representative Schmidt.
Thank you, Madam Chair. Is this a question? This is a question of the chair. Is this an early bill?
Oh, I knew somewhere, but I don't have it in my head. I'll
Okay.
get back to you on it.
Okay. Is it going to a
It
subcommittee?
is definitely going to subcommittee.
I assumed that, but I never
Oh,
like
yes.
to assume things, if I can ask. So the subcommittee situation, because we're talking about a lot of people and potentially a lot of money here, so I'm going to restrict some of my questioning to the subcommittee. But Director Courtney, roughly how many people are we talking about here in New Hampshire?
I think about 10,000 maintain their LNA licensure. That doesn't give us a good idea of who's practicing. So a lot of people will just maintain their license without regard to whether or not they're using it.
And how many pink cards do we have? We have a number of people here interested in this bill. How many pink cards do we have from?
There are 6 people regarding medical imaging, many of them students. One person that I believe is concerned about the Registry of Medical Technicians, and 3 people regarding the Board of Nursing.
Thank you.
So. All
Okay,
right.
We're good?
Okay, thank you.
Thank you for
very
your time.
much, and good-
Appreciate it.
Ben Bradley with the Hospital Association, since that's the employer of most of these folks.
Looks like it must be.
It's early.
Good morning, Madam Chair. I'm going to pretend I made the morning testimony. Follow my written testimony. My name is Ben Bradley, for the record. I'm the Vice President of State Government Relations with the New Hampshire Hospital Association, representing all our 26 community hospitals as well as specialty hospitals throughout New Hampshire. As you may know, last year's budget negotiations contemplated several provisions to reform professional licensure in the Office of Professional Licensure and Certification, including the consolidation or elimination of certain professional boards as noted by the sponsor. HB 1410 mirrors many of those changes proposed last year in HB 2. With regard to changes proposed for licensed nursing assistants, it appears LNAs will be able to retain their title as licensed nursing assistants, but instead of applying for licensure through the Board of Nursing and paying a licensing fee, the Office of Professional Licensure and Certification and the Board of Nursing will simply require their registration, which is in line with federal regulations. Additionally, the Board of Nursing would still retain oversight of LNA education programs and ensure integrity and accountability. We believe licensed nursing assistants should be given the opportunity to weigh in on how these changes.
Excuse me, Mr. Bradley, you don't need to read this to us.
Okay.
We've all, it is a requirement for membership on this committee, so I
Okay.
check it. What,
Understood.
what's your, if you would just explain the highlights to us, it's much more effective.
Sure. So we believe the licensed nursing assistants should be able to weigh in on how the changes could be beneficial to their profession. When it comes to repealing the Medical Imaging and Radiation Therapy Board, we believe that a thorough analysis should be done to continue to be done to determine whether New Hampshire would be an outlier among other states, and the consequences of repealing the license for these, whether the consequences would be in the best interest of the professionals licensed. As it relates to the Board of Registration for Medical Technicians, at this point we're neutral. Our hospitals interact with the Board of Medical Technician Registry regularly. However, we're uncertain of the value that the registry brings to their role of ensuring public safety is supported. We would encourage all parties, including individuals subject to the registry, to engage and fully evaluate the scope and function of the MedTech registry. Thanks for the opportunity to weigh in.
Are there questions? All right, thank you very much. Representative Gould, do you have a question?
I do, thank you. Can you answer whether or not all the hospitals in your association require background checks, criminal history background checks for LNAs?
Yes, my understanding is they do as part of their accreditation requirements for staff.
Thank you.
Working in their hospitals.
All right. Rebecca Shy.
Hello, my name is Rebecca Sky. I'm the Executive Director of the State Commission on Aging, and sitting here with me is
Susan Buxton. I'm the State Long-Term Care Ombudsman.
and also a member of the New Hampshire State Commission on Aging. The New Hampshire State, thank you for the opportunity to speak with you here today. The State Commission on Aging was created during the 2019 legislative session. Its chief charge is to guide the state to the governor and the state legislature on issues related to aging. And with that in mind, we did want to provide some input on the bill that you're considering, HB 1410. I do have a written testimony that I will share with you. It compiles some points raised by various commission members regarding this bill. As it is written, the State Commission on Aging and the Long-Term Care Ombudsman's Office oppose it. Both the portions related to med techs and the portions related to removing the licensure of nursing assistants. I'm just going to hit a couple of the highlights from it. Let me see. So among the use of a registry does not enable a board to determine the scope of practice of nursing assistants or med techs. That is to identify what they are permitted to do or not do. Healthcare is a dynamic profession, and those who practice healthcare must continuously adapt their knowledge and practice. Without these boards, who will make the decision about what the scope of practice is for these professions? There is concern about that related to LNAs, that federal regulation requires nursing assistants to receive 12 hours of annual continuing education. Without the licensure, there's questions about how that will, whose burden will that fall to maintain that that level of continuing education. And there's concern that it will fall to employers. Reading down, so licensed medical, so LNAs are in every sector of the healthcare industry. Licensing of nursing assistants creates a higher standard of safety. The Commission's understanding is that LNAs do represent a disproportionate number of complaints that are made to the Board of Licensure. Removing the licensures, it just does not seem advisable in this circumstance. Less oversight doesn't seem to ensure this safety in every sector that we need. I just want to make sure there's a particular point that you wanted to raise.
Yeah, I think one of the other points that should be considered is that the licensure adds a certain stature for licensed nursing assistants. And at a time when we really want to raise this profession up due to the critical workforce shortage in healthcare, this could be perceived negatively that they're losing licensure and instead becoming a registry. And I would suggest that it, as Director Courtney alluded to, looking to streamline the process of the registry and the licensure to make it a little less cumbersome for those individuals, so we continue to have a licensure which begins to set that career pathway for individuals who become nursing assistants to continue their career in healthcare with additional licensure.
Representative Schmidt.
Thank you. So, because I'm not sure how long your testimony is going to take, I'm wondering whether you can just address a remark you just made. So if that proposed or contemplated change were to go through, would that have an impact on the cost to the LNAs themselves in terms of registration?
There is no cost for the registration. There is a cost for the licensure, which, as Director Courtney, addressed, does not cover the cost of the licensure, and that would have to be, I believe, would have to be studied how to address that.
Okay, thank you.
Thank you.
There's just one final point that I would like to make from this. Licensed nursing assistants are individually accountable for the professional standards under their license. However, certified nursing assistants work under the guidance and direction of a licensed nurse, who is then accountable under his or her own license for their performances. Nurses have a voice that they are not comfortable accepting this responsibility, and this raises concerns for the additional turnover of licensed nurses in long-term care. That was raised to us by a long-term care provider.
Thank you. That's a very valid point. Representative Schmidt.
Thank you, Madam Chair. So As was indicated in earlier testimony, there are some 10,000 LNAs in New Hampshire currently. My understanding is that we have a somewhat different structure in New Hampshire than virtually all the other states. To the degree that we would entertain some kind of change, how much of a disruption would that make to these 10,000 individuals in New Hampshire?
Depends on the change, I'm sure.
I think that would be my answer. It would depend on what the change is. But as I said, I think we need to consider that we're not devaluing these individuals that are doing this work.
Representative Gould?
Thank you, Madam Chair, and thank you for taking my question. I support 100% what you're saying in terms of status for licensing. My question is, I heard Director Courtney say that really the registration is a license and would be considered a license, and that by streamlining and combining the two, is it really a change in status, or is it just that we've added this additional burden that we can redefine what's currently called registration on a list to licensing? Would that satisfy it, do you think?
In all honesty, it wasn't clear. A registry is different than licensing. It's not clear. Would an LNA be able to say that they're still an LNA, that they're a licensed nursing assistant? Would they become a CNA, then a certified nursing assistant? And does that still make them feel like they are part of an equal member of the healthcare team providing vital care? These are people who are the most intimate of almost anyone on the healthcare team with the people that they're serving, providing very personal care.
Thank you. I was one, and my daughter has her doctorate as a nurse practitioner, so thank you very much.
Okay.
Representative Mangiaputi?
Thank you, Madam Chair. A quick question in terms of how many LNAs, how many CNAs in the state?
I believe the Board of Nursing would be better able to answer that question.
Okay, thank you.
Correct. But this State Commission on Aging has studied the issue of what is the workforce that we need in this state. There's a national organization, PHI, that studies the direct care workforce. They feel they have made estimations that we will need a significant number of more certified licensed nursing assistants in the future.
Thank you. Representative Brown?
Thank you, Madam Chair, and thanks for taking my question. Going back to something you said, it might be outlined in your written testimony a little bit better. You said less oversight doesn't ensure safety. At least that's what I wrote down. You may not have said those exact words, but and anyone else that comes up to testify subsequently, I'd be interested to hear their thoughts on that. So this, you believe that this change in process might result in less oversight, and less oversight could be a safety concern. Am I translating what you said? I think I asked you 4 questions.
So I think that when we talk about some of the requirements of the licensing versus the registry process, we have a workforce that's very transient. And I think that the benefits of having the responsibility of licensure, which puts the responsibility on the individual, is probably going to provide for better oversight, if that makes sense. An employer is not going to have the average employer is not going to have a long tenure with that individual to be able to maintain their oversight of their continuing education, for instance.
Okay, thank you.
And it's my understanding of the process that and I do not want to speak for Director Courtney and but it's my understanding that the Office of Professional Licensure is moving towards conducting the investigations, and that the boards are moving towards the adjudication process of overseeing of hearings related to complaints. And it's that type of process. If you lose one piece of that, what happens to the whole of the process as a whole? I think that's where some of the concerns are coming from.
Thank you. Okay. Representative Schmidt, brief one.
Thank you. Are you going to, either or both of you going to be available for the subcommittee?
Absolutely.
Thank you.
Okay. Thank you very much. All right. Oops. Probably going to mangle this name because Danny Dimple for representing the Nursing Association.
My handwriting was really bad on that one. My name is Pam DiNapoli. I'm a registered nurse. I live in Manchester, and I'm a member of the New Hampshire Nurse Association Commission on Government Affairs. I'm not going to take a lot of your time because the previous testimony addressed a lot of the issues that I want. So just to reiterate, this was in HB2 last year. It was pulled out. At that time, New Hampshire Nurse Association opposed those provisions. We were happy when it got pulled out for further study. I think there are some improvements made by this HB 1410, but there are still some concerns that we have that need continued thorough study. Some of those are the onus on the employers. So the previous discussion about regulation and oversight would fall to the employers. We do have a document that shows that these registries, there's a number of people that are maintained on the registry despite disciplinary action, despite having lost their certification, so to speak. So there are some concerns with maintaining a registry. I think that we're concerned, as also was previously talked about, the impact on the pipeline. When we surveyed our licensed nursing assistants, 70% of them wanted to maintain the license because they felt like the professional stature was really important to them. We are concerned that the scope of practice isn't well defined. So currently there's a different scope of practice for LNAs that work in a nursing home versus a hospital. And so those would have to be justified. There's concern about delegation. So if these individuals are no longer licensed, would a licensed registered nurse be able to delegate to an unlicensed person? And that's a concern to us. There's a concern about what we call these people, and it seems silly because a nursing assistant is a nursing assistant, but are we calling a licensed nursing assistant somebody when they're not licensed? A certified nursing assistant would be different, but have the same scope of practice. Are they in the bill itself? It was called nurse's aide, nurse's assistant, licensed nursing assistant. So the title needs to be justified and then also shared with those current LNAs. And then finally, what's the authority for the Board of Nursing? So will the authority of the Board of Nursing for disciplinary action still be as rigorous as it may be now? Because it was pointed out that there are a number of LNAs who are in the pipeline for disciplinary action.
Thank you. Are there Representative Schmidt?
Thank you, Madam Chair. So registered nurses, RNs, are in point of fact licensed, even though they're still called RNs. Nobody says registered nurses anymore, but it's become the title, like CPAs are certified, called certified. You know.
And your question, please.
Yes. So how does that aspect, touch on the question you just raised?
That's a good point. I think registered nurse is an accepted title throughout the country. What we have the problem with the CNAs, so in some, like Massachusetts, they're called certified nursing assistants. In New Hampshire, they're licensed nursing assistants. So the name becomes, I think, important because we want to talk apples to apples. And I think that was talked about with the transitory nature of this job. You could be a CNA in Massachusetts, come to New Hampshire to be an LNA, and there's some confusion there. So I think that that's really, it's just for purposes of clarity.
Thank you.
and if I can just make one last point on the composition of the Board of Nursing, I think that there was mention that that the board would be right-sized if they cut it down from 13 to 7, and I think we need to hear from the Board of Nursing whether or not that's going to meet their efficiency needs. Because if the purpose of all of this is efficiency, then we have to have a right-sized board as well.
Thank you. Okay.
Thank you.
Representative Mangiaputi?
Thank you. I just have a question for you. I can ask, this is the right person to ask my previous question, correct, Madam Chair?
No.
No? Okay, I'll defer.
She's a member of the Nurses Professional Association.
Right.
Samantha O'Neill is here for the Board of Nursing. I really hope you won't need 10 minutes.
Good morning, and thank you. My name is Samantha O'Neill, and I'm the public member and chair of the Board of Nursing. I've been on the Board of Nursing since September 2017. I do have a 4-page testimony that has been given out. I don't plan to read it. I think the best use of the time would be for me to highlight some specifics and then answer some of the questions that have come up that I think were posed to other people but were meant for me. So the board oversees advanced practice nurses, registered nurses, nursing instructors, licensed practical nurses, licensed nursing assistants, and medical nursing assistants. We have just shy of 50,000 licensees. The number of LNAs in the state currently are 12,000, and approximately 1,000 of them are medical nursing assistants. You need an LNA to be an MNA. So you need to have that license prior to being a medical nurse assistant, which allows you to dispense medications, which is a huge component in our long-term care and facilities and our nursing homes. We currently do not have certified nursing assistants, which was what your question was. We do have a lot of my testimony on behalf of the board has been stated previously by speakers that came before me. We do have concerns, Representative Gould. We have concerns about the background checks as well. As a note, 81% of all LNA applications come before the board due to background checks. There are many that do get their license, but many of them have to come before the board to speak about their background so we can have an understanding of what happened and what they have in place for them to be practicing actively within the community. Because LNAs, they're in the hospitals, but they're also home care, and also long-term care, and that's where our most vulnerable patients are. And we want to make sure, and we have had people before us for the board for theft, and taking advantage of people in home care and also long-term care facilities. So we want to make sure that they have clean background checks to make sure that they are safe for our citizens.
Excuse me, you said that 81% of the applicants have something on their background check that has to go to the board?
Correct.
Thank you for that information.
You're welcome. And also 39% of the complaints that come before the board are for LNAs. 39%. There was someone who asked, I believe it was Representative Schmidt, regarding how would the change impact the LNAs. It would depend on what the change is. I think, from a board perspective, we understand that there's challenges with the workforce. We face it every day. I am a human resource professional. I worked 8 years in healthcare. I currently don't work in healthcare right now. So I understand firsthand the challenges with workforce, and we obviously have made changes on streamlining the process for licensees, making it easier, but also making sure there's a balance between streamlining the process and also making sure that the people are safe to practice and they have the skills needed to practice to take care of patients. And there's a balance there. And I think, you know, the board feels very strongly that we would be willing to have conversations with any of this committee, also the New Hampshire Nurses Association and any other individual from the constituents that would be able to work collaboratively to come up with a solution to this, to be able to make sure that we're meeting the needs of the workforce while also making sure that those in the workforce are practicing safely and not cutting corners to make sure that we have people to do that. We want to make sure that we're having the right people do that. And I think, you know, one of the missions of the Board of Nursing is making sure that people are safe to practice and make sure the members of our community are safe. And that is the most important for us, as I'm sure it is for all of you.
Thank you. Representative Mangiaputi?
Thank you, Madam Chair. Thank you for that clarification. So now having done a non-medical in-home care coordination and starting something in New Hampshire in my previous life, but with that, where does the home health aid fit in with LNA, CNA, if we don't have CNA? So are they taking the place, especially for in-home care?
So there's different positions for home care. Those that are not licensed do not fall under the purview of the Board of Nursing. So I honestly don't know how many are providing home care, but they cannot do the work of a licensed nursing assistant. So people can't practice outside of their specific scope that's relevant to their license. And if somebody is not licensed, they should not be doing things that are responsibilities of those that are licensed.
Thank you.
Yes, I'd also like to speak about the composition of the board. Thank you. That's a big piece for us. So the board is made up of a cross-functional group of people. And we were just approved in 2023 to increase our number from 11 to 13, which was just done not even a year ago. We have a cross-representation of APRNs. We have 2 public members, we have LNAs, RNs, and LPNs, all of which have different experience. So we have people that have home care experience, long-term care experience, ambulatory, hospital, and we have all of those different licensees, of which again are close to 50,000, come before the board for a variety of reasons. And tapping into that expertise and knowledge of that cross-functional group of people is really paramount to making sure that we are, one, understanding best practices, understanding the situation of whatever is coming before us, and we tap into that level of expertise every single board meeting to make sure that we're making sound decisions, because the decisions we're making are not just impacting somebody's position, their livelihood, their license can depend on what they've done versus our decision on what to do for them moving forward. So having that level of expertise is paramount, and decreasing that number we honestly don't support that and feel that it's going to have a negative impact on our decision making.
Thank you. Does the Board of Nursing have any trouble getting a quorum?
We do not at all. Even in our emergency situations, we do not have a problem coming up with the quorum at all.
Thank you.
Mhm.
Thank you. Representative Broda?
I wanted to ask you to share with the board what an MNA does, because it's very important what their responsibilities are as far as medication and the kind of training that they get, and that this is the kind of work that's available for an LNA if they wish to
Excuse
expand
me,
their.
Representative Broda. That's fascinating, but I kind of think that belongs in the subcommittee. Would you agree?
Oh, okay. Thanks.
Could I just comment? I won't answer specifically, but you brought something up that I think is important, is a lot of the LNA, the MNA, the RN, the LPN, those are all career advancement opportunities for people in the nursing practice. So, you know, when you look at the scope, it would be LNA, MNA, LPN, RN, APRN. So there is a direct career opportunity and growth path for people that do need various levels of experience to help them in their advancement of care and licensing within the the workforce and the hospital association.
Thank you very much.
Thank you.
I hope that we can get some help from the board and our subcommittee.
We would be
Yes.
honored to participate. Thank you.
Thank you so much. That will help. Brandy Kusan? Please turn your microphone on. Thank you.
Good morning. Thank you for this opportunity to be here today. You guys have my written testimony, so in the timely constraints we have, I'll kind of paraphrase. Madam Chairperson, all the members of the House Executive Departments and Administration Committee, my name's Brandy Cusson. I am the president of the New Hampshire Society of Radiologic Technologists, as well as the board chair for the State of New Hampshire's Medical Imaging and Radiation Therapist Board. I am here before you today as the main voice of the medical imaging professions in the state of New Hampshire, and we are committed to the advancement of education and professional status of credentialed technologist. I'm here today asking on their behalf as well as mine that this committee vote HB 1410 inexpedient to legislate. The biggest issue that medical imaging faces is this going away, which will increase unsafe practice for the patient, and not only for the patient, but for the practitioner as well. The patient rarely is in a position to judge the qualifications of the operator or the quality of the examination, let alone their radiation dosage. The chest X-ray, when performed by an uneducated, untrained operator, has the potential to deliver 100 times the radiation dose to the patient as the same procedure performed by a properly educated radiologic technologist. Education, knowledge is the paramount for safety for our patients. And that's really what we need. If we take away licensure, then we're taking away that level of oversight and safety for our patients and for the people that are working in the industry. If you don't know how to operate the equipment or to expose it properly, then you're going to expose yourself to unsafe radiation levels, just as you would to the patient. The New Hampshire Hospital Association was asked a question about what the majority of the United States are in regards to licensure, and over 45 states have some form of licensure in their state. Happy to answer any questions that anybody has.
Representative Schmidt.
Thank you, Madam Chair. So you understand that this bill involves a lot more than your profession. So the idea of ITL doesn't really resolve the issues that this bill, tries to deal with. So would you be, open to alternatives to an ITL motion?
Sure. Yeah, I would love if you would strike us from the bill. That would be great.
Thank you. That's nice and simple. We will consider it.
I was not asked to ask that question, but it's an obvious one.
All right, thank you. All right, thank you for your testimony. All right, and I have 4 students. I hope that you will be brief and not repeat what's been said already. Rhonda White.
Good morning, Madam Chair and committee. I have a written testimony from Dr. Sprague, the Chief Radiologist at CMC. May I read it for the record?
You can put it into the record. Do you have copies for us or just one?
It is in Brandy's packet. The packet that was passed up prior.
We will be reading this. If you could give us the highlights, we would appreciate it.
Absolutely. Dr. Sprague agrees with the New Hampshire Society of Radiologic Technologists, the American Registry of Radiologic Technologists, and the American Society of Radiologic Technologists that removing licensure in New Hampshire does create a safety hazard for both patients and employees operating the medical imaging equipment. As a radiologic technologist, we spend at least 2 years in school. Most of us, it ends up being about 4 by the time we're done learning anatomy, physiology, radiation physics, patient and personnel safety. And without that, you could really be putting a lot of people at risk of overdosing radiation and, for instance, injecting an air bolus through a CT injector or aspirating barium if improperly given to a patient.
Thank you. That's very clear. Question? All right. Thank you very much. Yes, Representative Brown.
Thank you, Madam Chair. So following up on what I asked before, you see that if this passes, it will change the amount of education required, and therefore that's a safety issue.
Yeah, actually, Dr. Sprague did
I-
mention that.
Yeah, I'm trying to read this. I'm sorry, I apologize. Continue.
Okay.
He did mention that hospitals would no longer be required to hire licensed technologists, which could leave a lot of gray area in what kind of education is required for the job.
Okay.
Okay. Fair
Okay,
enough.
thank
Thank
you.
you very much.
Thank you.
All right. Jessica Horton.
Good morning. My name is Jessica Horton, and I am a registered radiologic technologist for the state of New Hampshire. And I am also one of the 2 program directors for 2 of the accredited radiologic technology programs in the state of New Hampshire. So just to summarize, I'm on the New Hampshire Society of Radiologic Technologists board. So I'm an advocate and an educator and a practicing radiologic technologist on a per diem basis. Primarily, my role is to educate students in the state of New Hampshire to go out and serve our communities. And in that role, one of the most important aspects of their education is learning human anatomy and physiology, proper radiographic positioning, and radiation protection. So Brandy Cusson came up here earlier and mentioned the importance of proper positioning regarding any sort of imaging modality that is performed. And without proper positioning and radiation protection, basically an individual that would be performing any sort of medical imaging study would be guessing how to perform that study. So I'm asking you to please consider my strong opposition to this bill, because the fact that our patients would not be receiving safe care in any of their medical imaging studies.
Thank you. Representative Gould.
Thank you, Madam Chair, and thank you for taking my question. Will you be available for the subcommittee on this bill?
Sure.
Excellent. Okay. Thank you for your testimony.
Thank you.
Connor Fugere.
Thank you for allowing me to speak today. I just wanted to voice my concerns to this bill due to patient safety. Whenever you're a patient in a hospital, you expect that you are going to receive quality care by individuals that are well capable of doing their job, and especially with radiation safety. I'm currently a senior student, and there's been a lot of learning curves and different aspects that go into this. And whenever you go in, if we didn't have properly trained staff members that are capable of knowing what they are doing, this could cause many safety concerns. It could lack the quality of care. It could endanger the patient along with yourself. And with that being said, it is rather dangerous to have people that could slip through the cracks without this licensure in place and cause harm to our community as a whole when medical imaging is necessary in a hospital or orthopedic setting.
Thank you for your testimony.
Thank you for allowing me to speak.
Oh. Britt Crathern.
Good morning. I'm Brett Crathern, and I'm here to speak on the behalf of the imaging programs. I just want to bring up the fact that getting an X-ray is a prescription. You're prescribed an X-ray, you're prescribed the dosage of what it takes to get the proper image. Without a properly trained person, how do they know what dosage? Each machine you kind of learn. So each machine at every facility, you got to learn a little bit to tweak it so you're given a proper dosage. That's all I really have to say.
Okay. Thank you for coming to talk to us today. Questions? Okay. Thank you very much. Dr. Sherman?
Thank you, Madam Chair, and thank you for the opportunity to speak on this bill. For the record, my name is Tom Sherman, former state rep, state senator, and a retired gastroenterologist from Rye. I'd like to speak to two parts of the bill. I think the nursing rules have been covered by people much more expert than I. But on page 6, lines 22 through 26, I would ask that you strike this repeal. Last year, I believe we had a repeal of the MedTech Board before you, and I spoke at length about the history of the MedTech Board. A brief reminder is in 2011, my work partner and I discovered a hepatitis C outbreak at Exeter Hospital. 32 patients were involved. Senator Cataldo's mother was one of the victims that died of that. The bills that came out of that, at least 4, made New Hampshire one of the safest states in the country against drug diversion. And the criminal who actually did that was a radiology tech and there was no mechanism to actually track him. So Representative Copeland and I came together. Representative Copeland is a Republican. We came together and we took a bill that already existed, which was the bill to create the Board of Medical Technicians, the Board of Registry, and worked on it in a bipartisan fashion for over a year to come up with the MedTech Board. The goal of the board, and this is what's critically important, the goal of the board was to close a gap in state monitoring of people who have access to patients and dangerous drugs like opioids. That was the goal of the board. So if you are a medical assistant, you're not licensed or registered or otherwise classified anywhere in New Hampshire, and that's still true unless you have access to patients and controlled substances. Then you have to register with the Board of Medical Technicians. Is this, a decade later, the best way to handle this, to close that gap? I'm not sure, but I think the fact that we have not had any further outbreaks in the state of New Hampshire may be a testimony to this is at least a smart way to do it. But as Director Courtney has said, they have trouble staffing the board, and there may be another alternative to it. But repealing it altogether reopens that gap. According to the federal attorney who prosecuted Kwiatkowski in that case, 8,500 people were put at risk nationally by one person, and his final stop was at Exeter, in Exeter, New Hampshire. And we stopped him in New Hampshire. It was the 3rd largest hepatitis C outbreak due to drug diversion in the country, and many people got sick, many people died, and most of them were elderly because it happened in the cath lab. So I would ask that you not repeal. I would commit to working with Director Courtney to some other less cumbersome, more efficient way of monitoring people. This is not a clinical evaluation of people's performance. It's simply a way to make sure that if there is somebody in the state of New Hampshire in this position which I've already defined, that we know about them, and we also know if there's a disciplinary action or even a criminal prosecution of them. That would keep the gap closed. The second part that I want to speak on is the repeal of the Board of Radiology Technicians. This bill, this board was created by Senator Carson, who is chair of eDNA on the Senate side.
Not anymore.
Not anymore, but I'm old. She was when I was here. Lots of expertise on the boards coming from Senator Carson. But the most important part was one of the pieces of testimony that happened during the formation of this board, which wowed the committee at the time. And that was when somebody said that in a dental office, the receptionist did the actual x-rays. And it was somebody who was on the committee in the House. And the radiology tech who was actually testifying at the time said, "Did they shield you?" And they said, "No." The gentleman's face went white. That's what we're going back to. We're going back to receptionists being able to perform potentially dangerous procedures because they don't know, they don't have the education, they don't have the certification that this board provides in how they actually dose the radiation, how they protect the patient and themselves from the radiation. So I would ask you to give us a chance to close that gap in another way if there are problems with the Board of Medical Technicians rather than a repeal. And the second one is please leave the Radiology Tech Board intact. It's critical and it will be life-saving. Thank you. I'm happy to take any questions.
Thank you. Just a brief one, Representative Mangiapudi.
Thank you. I haven't even turned my microphone off. Sorry. So how will this rule change affect the larger sector where home care, aging in place, outside the hospital kind of thing? So the oversight on that critical function that LNA, the technicians all provide, will this reduce by repealing this? Will that reduce the oversight?
You know, honestly, I think you've had people who are much more expert already speak to that. And I'm just a simple country doctor. I'm not a nurse. So I think you've had the experts already talk about that.
Yes,
If that's
thank you.
okay.
No, we'd rather you didn't waffle for a bit. We're, all right.
Oh, I'm not waffling, Madam Chair.
Thank you very much. I appreciate that. All right, we have another hearing at 1:15. Unless there is someone who needs to speak on this bill now, is there? Okay, thank you very much for being here. We will take that information to the subcommittee, and I'm going to close the hearing. For the purposes of the committee, we will not have a session next Thursday. We will have a full day of hearings. Next Thursday, the 25th.
a regulation and licensure of deputy physicians. And so Representative Brian Cole, are you presenting the bill? Okay.
Thank you, Mr. Chair, members. 1427 is establishing the regulation and licensure of deputy physicians. So this is a bill that has come up in the past, but there was always a problem with the verbiage of the title. They wanted to call it assistant physician or physician assistant. So you can see where that's very confusing between the two. So we changed the language to deputy physician to make the distinction. So that's one of the first major distinctions that's in this bill. Now, why are we asking, why are we bringing this bill to the committee and for New Hampshire? Currently, there's about 5,000 people in the United States that have all the qualifications to become a doctor, but they can't find the residency to do so. So they passed all their tests, they passed all their exams. The last thing they need to do is to follow or shadow somebody in the medical community to get that residency. What this bill does is allow that door to open up for New Hampshire. Now, there's already 9 states in the country that have enacted this, and they're taking all that medical talent and bringing it to their states. I think that's something that we can do here for New Hampshire. So that's a very brief overview of the bill. All the technical stuff and all the RSAs, I'm sure you can look that up on your own. You can go through that technical data. But that's the crux of the bill. So I'll entertain any questions. I know it sounds kind of simple. It's a complicated bill, but I mean, that's really what it's about.
Great. Thank you for your testimony. Are there any questions?
Sure.
Okay. Representative Grote?
Thank you. What do you mean they don't have availability of residency? I don't understand.
Residency, I passed out, I put a thing on everybody's desk. So there's an article related to this, and then there's testimony from Ross Terry, who was a former rep. He's also a pharmacist. So residency, you need to be matched up with a doctor, and you shadow this person for X amount of time, and you learn how to, become a doctor. That's how you learn how to get your license to practice medicine. But there's only so much of that pairing in the United States. In 2021, there was 4,000 people looking for residency. This year, it's 5,000 people looking for residency. So it's becoming more and more of a problem. So it has to do more with pairing and opening up that avenue. There's only so much residency. So these people can't find the residency to become a doctor.
Follow up? So residency is usually specific to a certain segment of the medical field. For example, you have anesthesiologists, you have thoracic surgeons, you have orthopedists. So is there a specific residency that's not available to these individuals?
It's the fact that there's only so much residency. There's only so much residency available. So if you make this residency available to somebody that is a specialist like that, and they can shadow 2 or 3 people, they can open the residency that way. They can earn the residency that way.
Thank you.
Yep.
Representative Schmidt, do you have a question?
Well, I know that residency, to my knowledge, is usually involves an affiliation with a teaching medical school. So Dartmouth has medical school, right?
Mm-hmm.
But UNH does not have a medical school, I believe.
I do not know.
I believe so. Do we have anybody from Dartmouth here that can talk to us about this situation?
Representative Cole, you said there's only so many residents. How many, do you have the number for medical school graduates versus residencies?
The number that I have are people that have passed all the qualifications federally to become a doctor. They just need to find a place to find that residency. And right now, There's currently about 5,000 people in the United States that can't find residency.
Ah, thank you. That's a is that 5,000 per year or 5,000 accumulative?
In 2021, it was 4,000 for the entire United States. This year, or 2023, it was 5,000. So it's a growing problem.
Thank you.
Yep.
Okay, thank you for your testimony.
Thank you.
Okay. Ava Hawks.
Good afternoon, Madam Chair, members of the committee. I just passed out a stack of my testimony, so I'll introduce myself a little bit slowly. For the record, my name is Ava Hawks, and I am the Director of Advocacy for the New Hampshire Medical Society. The Medical Society strongly opposes House Bill 1427. House Bill 1427 seeks to allow medical school graduates who have not completed graduate medical education or residency, or completed the medical licensing examination series, a series that tests a future doctor's medical knowledge and preparedness for independent practice, to become licensed healthcare providers called deputy physicians, as this bill sets forth. The provisions set forth in this bill would dramatically lower the standard of training and competency demonstration that our providers across specialties and the state work so hard to implement. And frankly, the bill would unjustly risk patient safety in New Hampshire. The American Medical Association, or the AMA, the largest and only national association that convenes 190 states and other specialty medical societies, has also gone on the record opposing any efforts in states that create pathways for deputy physicians, or previously coined as assistant physicians, in proposed legislation in 2019 that was defeated as well. And these efforts to circumvent the traditional residency training and standards put forth by the Accreditation Council for Graduate Medical Education Program, or ACGME, which you'll hear experts behind me speak to more eloquently today. While the Society's membership is acutely aware of the impact that the current healthcare workforce shortage has on access to care in New Hampshire, our state's physicians and the medical profession as a whole are not willing to risk patient safety and health outcomes by licensing medical school graduates who lack the imperative and life-saving skill sets acquired during residency training, all in the name of increased access to care. For these reasons, the Medical Society joins countless others, including the New Hampshire Board of Medicine, in strongly opposing House Bill 1427, and encourages the House ED&A Committee to recommend an expedient to legislate on this bill to ensure that we continue to prioritize, not undervalue, the medical education, clinical training, and high standards of our state's physicians that have led to our high-quality healthcare system. I am happy to attempt to take questions, but I know that there are a number of physicians and experts behind me that will speak more eloquently to the intricacies that go into the residency programs in our state and what those programs look like.
Okay, are there specific questions? It's not required, Representative Brown, but go ahead and ask.
Thank you, Madam Chair. As you read this, would a deputy physician working under a physician, would that be similar to a residency? And anyone following you can answer that question.
So I don't want to football, but I think the providers and physicians in the room could really eloquently speak to the differences between the process that's outlined in this bill in comparison to how these residency programs work in our state. Thank you.
All right. Representative Smith.
Yes. Excuse me, but how long are residency usually? Is it a year, 2 years?
So it varies depending on the specialty. On average, it's anywhere from 3 to 5, as I understand it. And there are some surgical residencies that last longer than that. And I'm confident folks directly behind me who plan to testify can speak to their experiences there, have facilitated residency programs in our state.
Okay, let me think about that.
Okay. Thank you.
Thank you.
Christine Stoddard.
Good afternoon. My name is Christine Stoddard, and I'm the Director of Public Policy at Bi-State Primary Care Association. We are also opposed. Bi-State Primary Care Association is a nonprofit that works to expand access to healthcare services. especially in medically underserved areas, which is the areas of the state that this bill is targeting. We also represent New Hampshire's community health centers, which are regulated by the federal government, and they operate in medically underserved areas. Our community health centers cannot employ the clinicians that this bill is proposing to create. We rely on federal malpractice insurance to ensure our doctors and the safety of patients in New Hampshire. They would not cover the clinicians that this bill is proposing to create. We are also not able to get reimbursed for the care that would be provided under this bill by any carrier, especially CMS, the Centers for Medicaid and Medicare Services. We do not have the ability to float healthcare services provided by clinicians that we cannot get reimbursed for. So in summary, we can't afford to employ this type of clinician that this bill is proposing to create. So we would ask that you recommend the bill be inexpedient to legislate because we can't employ them. We would rather create additional residency programs and more training opportunities for clinicians than reduce the requirements to practice medicine in the state of New Hampshire. I'd be happy to answer any questions if you have them.
Okay, thank you. Representative Mangiapudi.
Thank you, Madam Chair. Thank you for your testimony and thank you for taking my question. Is it true that currently existing residency programs for doctors, they are not completely filled in some places because people are burnt out and don't want to get into medical field as a practicing doctors? Have you heard that?
Thank you, Representative, for the question. I think that the workforce shortages that we are experiencing are very complicated. There's not just one reason why we are experiencing shortages, but yes, there is definitely burnout amongst medical professionals across the country and the state of New Hampshire.
Yes, Representative Gould.
Hi, thank you, Mr. Chair, and thank you for taking my question. My question is a follow-up, and it has to do with residencies. And everything I've heard, I've never experienced one, but everything I've heard and read from doctors about residencies is that the way they're set up, they are very unhealthy for the people enduring them. Do you have anything to do with how residencies are set up? And as an alternative to this, if we're going to expand residencies, can they be made more healthy for the people trying to do them?
I think that's beyond the scope of this bill, to be honest with you, Representative Gould.
Thank you. I'll accept that.
There.
Thank you.
You're not responsible for residency. You just take the doctors.
We are not, Representative McGuire.
Thank you. All right. Any other questions?
Thank you.
Okay. Pam Napoli.
Thank you. Pam DiNapoli, New Hampshire Nurses Association. I'm a nurse and recently retired from the University of New Hampshire. The New Hampshire Nurses Association, like we did in 2019, opposes this bill. We recognize there's a need for primary care providers in underserved areas, but the solution as proposed is not HB 1427. Currently, the state licensed independent practitioners such as physician's assistants and advanced registered nurse practitioners. HB 1427 would offer medical school graduates a pathway to MD by practicing in this same independent practitioner role. In New Hampshire, ARNPs, nurse practitioners, like those in 25 other states, enjoy full practice authority, allowing them to practice free of MD supervision and with similar skills and competencies. The American Medical Association has long advocated that the education and training to be a medical doctor must be comprehensive, including classroom, laboratory, or direct care experiences. Since the NP role was established in 1965, research has consistently demonstrated the excellent outcomes and high-quality care provided by nurse practitioners. The body of literature supports the position that NPs provide care that is safe, effective, patient-centered, efficient, equitable, and evidence-based. There is no such clear evidence that medical student graduates who have not matched with an accredited residency training program can guarantee the same outcomes. Currently, there are 2,600 nurse practitioners licensed in the state with a pathway to train more. For example, UNH has the Advanced Nursing Education Workforce Grant, which is funding to prepare primary care family nurse practitioners and psych mental health nurse practitioners to provide care in rural and underserved settings. Currently, medical school graduates do not have to complete a residency program. However, they would need to complete a residency program to be licensed as an independent practitioner. Residency training means participating in graduate medical education. Once a doctor in training has completed their GME and has passed all three steps of the training, they can become practicing physicians. Medical residencies last anywhere between 3 or more years. To substitute this highly structured, regulated medical residency program with a practice program with a single practitioner has the potential to impact the safety of many of the most vulnerable patients in rural and underserved areas. This is a dangerous substitution. New Hampshire Nurses Association strongly opposes this legislation together with our practice partners.
Thank you. Questions? Representative Mangiapudi?
Thank you.
Thank you. I just have a quick question.
Over
Sorry.
Right over there in the corner.
Quick question in terms of the workforce shortage for physicians. Isn't that true that since New Hampshire does not have a medical school, state medical school, the only medical school we have is Dartmouth, that is creating an acute shortage to have physicians?
I think, like what was said before, that there's a lot of reasons for shortage. One of the reasons I was pointing out the nurse practitioners as independent providers is those graduates often stay in New Hampshire. And a lot of the evidence is that while Dartmouth is our medical school, not many of those continue to practice in New Hampshire.
And Representative Mangiapudi, it's not a local shortage. There's a nationwide shortage of medical professionals.
That's right.
Representative Brown?
Thank you, Madam Chair. This will probably come up in subcommittee more, but NPs as independent practitioners, do they require some kind of a residency or something of that nature before they get that far?
They have practicum hours that they have to complete as part of their program, yeah.
Thank you very much. Holly Campion?
Good afternoon, Madam Chair and members of eDNA. My name is Polly Campion. I am a former representative. I spent a year on this committee, and I recognize some of my former committee mates. Many of you are new since that time, but it was a fascinating process for me. I am a registered nurse, and I'm here today as a member of the State Commission on Aging. I also had the opportunity of testifying on the floor, actually, against the floor of the House against this bill the last time it came up, in 2018 and 2019. And except for the title, nothing in the text has changed. What I'd like to just reinforce, I have testimony that I emailed to each of you, and I have copies if you'd like. Let me just pass that around. I'm not going to read it all. You've had it in email, you have it in hard copy. I've spoken with some of you, but I'd like to make a couple of points to reinforce what has been said, but also to speak specifically about the effect on older adults of licensing this new form of providing care. We all recognize that there is a shortage of primary care providers, but this is a very flawed solution to that. And just to jump to the fact that we don't have enough residency slots in the country or in the state, Senate Bill 403 actually proposes providing funding to support a new family practice residency program in Coos County. So that's a potentially better way of addressing the shortage of physicians. It's already been stated, but I'll emphasize the fact that the deputy physician, the way this bill is written, would need to find essentially a mentor, a collaborating physician, who would then be responsible for designing the equivalent of a residency program. The language says with DHHS and with medical schools to be named. And I don't think that medical schools have volunteered to help put their energies into designing this training program versus those that have been approved by the accrediting boards. The deputy physician, as outlined in the text, would effectively practice in an equivalent way as a physician assistant without the benefit of being able to bill for services, as we have heard. The proposed grant program would further promote a second level of care to those already in greatest needs and at greatest effect of the fact that we have inadequate services, particularly in rural areas. The effect on older adults would be such that older adults, those of us as we age, and we all are aging, tend to carry with us our life experience that include chronic illnesses. The care that I need is much more sophisticated than the care that I needed when I was younger. We need care providers who are experienced and knowledgeable in diagnosis and recognition of the difference between an exacerbation of a chronic illness and a new onset acute illness. And this particularly may show up in cases in which memory starts to fade. It is not true that we all lose our memories as we age and we all develop dementia as we age. And often there may be a metabolic condition that causes changes in cognition or mentation. And if we have providers who have no experience or limited experience in patient care and don't have the support they need to gain that experience and that knowledge, we are much more likely to see mistreatment and misdiagnosis of acute exacerbations of chronic illnesses as well as new onset. In addition, I think the work, the rules, and the effort and expense required to set up this program would distract from all of those resources and the effort that actually could go toward a more significant solution. And with that, I ask that you vote ITL on this bad bill. I will also say the sponsor who introduced the bill mentioned that there were a number of states that have implemented this. I believe that that may not be the case. Missouri, to my knowledge, is the only state that has actually implemented this role and hired individuals into it. A number of other states in the 2017-2018 time period proposed legislation, but to the extent I was able to follow up on that, it appears that they have not been successful. And I know that there are experts behind me who will be able to speak to that to a greater extent. And with that, I'd accept any questions, but we have experts.
All right, thank you very much.
Okay, thank you.
Yep. Okay. Ben Bradley?
Thank you, Madam Chair. Members of the committee, for the record, Ben Bradley, Vice President, State Government Relations for the New Hampshire Hospital Association. I'm not going to read my testimony that went around to the committee, as many of the points we raise have been raised by others. I list in bullet form on my testimony each of those concerns. Want to reiterate our opposition to 1427 with several concerns. We have heard from colleagues in Missouri that implemented this, and they've shared their experience, challenges with securing malpractice insurance, challenges with securing reimbursement from carriers and contracting with insurance. I'm happy to take your questions.
Are there questions? All right, thank you for your testimony. Nick Perenchevich. Turn your microphone on, please. There you go.
There we go. Thank you. Let me see what I look like. My name is Nick Perenchevich. I've lived in the Concord area for 36 years. I'm a semi-retired general and vascular surgeon. I don't operate anymore the last 10 years, but I've continued to teach. And literally this morning with 2 Dartmouth medical students and 2 residents from Dartmouth. And I've done that pretty much my whole career in Concord, and prior to that for about 8 years in Boston when I lived in Massachusetts with medical students. So I have a fairly strong relationship with teaching, and it's been mostly in New Hampshire, entirely through Dartmouth. One of the questions, yes, there's only one med school at Dartmouth. There are other med schools nearby, and that's kind of critical in this bill because there's some discussion of it on page 7 of adjacent med schools and residency training programs. I'm not representing anybody other than myself at this point. The residency is something that I went through many years ago, but I also was the director of the surgical residency in Dartmouth. We've had a satellite in Concord for 35 years where surgical residents in their 2nd and 3rd year spend time, and I was director of that for about 15 years. It's really different than the exposure one gets to patients in med school. Did some calculation. The typical medical student spends their last 2 years in hospital seeing patients. So that's important because if you're going to take care of patients, you have to see patients before you get the green light to do that. And typically that's about 4,000 hours those last 2 years. If you take 2 years of residency, which no residency in the United States is 2 years, they're 3 years and more. There was a time it was 1 year, that was called GP, and you rotated through and so forth. But if you do 2 years of a typical residency with the time constraints, trying to be respectful of their illness, time and so forth, it's about 9,000 hours in those 2 years. So the typical residency is a little under 15,000 hours. And the difference is when you're a medical student, you're not writing orders. You're observing, you're studying, you're learning, you're getting tested, but you don't really have responsibility for the patient. You can't write an order. The residency, all of a sudden, it flips. You're writing orders, you're responsible, you're on night call, you're making first decisions. And after about a year of that, you're supposed to get tested, and that's called level 3. So there's a dramatic difference. There's a lot of responsibility that goes into the typical residency, no matter what field it is, primary care, surgery, whatsoever. First year residency in most places is very similar because it's being used to seeing patients. Getting to this exam part, well, I'll talk about step 3. They didn't talk about step 1 or 2, but 1 is after 2 years of med school. And what you're looking at is basic science. Do you know anatomy? Do you know physiology? Do you know the structure of the body? Do you know how to look under the microscope and look at slides and stuff like that? And once you start seeing patients after those first 2 years in your 3rd and 4th year, that second part of the exam has to do a bit with patients, but has mostly to do with recognizing diseases and understanding it. Book knowledge of diseases, basically pathology, both clinical, anatomical, and radiology and so forth. So I spend time with 3rd-year medical students, and they're nowhere near being able to take care of patients even at the end of their 4th year. The 3rd test, if you look up or Google what the 3rd test is about, is to whether they have clinical judgment. You don't get judgment until you're actually responsible for taking care of the patient. You need to have a year of that under your belt, and whether you're safe unsupervised. So residents take this test while they're residents after 1 year, somewhere usually between the 1st and 2nd year, sometimes the 3rd. But the goal is to have you to be safe unsupervised, and yet then more people than not end up having 1 more year of residency. So there's a lot involved. And with this deputy, we called it deputy physician now. The last bill, it was graduate physician. There isn't this testing of being able to make judgment. There was a time that states created their own level 3 tests, actually level 1 and 2. I'm old, I'm 76 years old, and when I finished residency, if I wanted to practice in Florida, finish my residency in Boston, go to Florida, I'd have to take a separate test in Florida. That doesn't exist anymore. It's been 45 years, I think, since Florida's had its own test. That's relevant also. I'm going to get on to, almost done with my comments, but the thing that disturbed me most about this bill was, I mean, we saw this stuff a couple years ago. It wasn't any different what I've talked about now. But this test, this previous bill was sort of a pilot thing. Does this make sense? Can we do it? And trying to get support, it didn't happen. This one isn't listed as a pilot bill. It basically is more detailed. It's a lot longer. But if you go to page 7, line 17, I'm going to quote what it said there. Basically, it has a pathway for deputy physicians to become fully licensed in residency training. If you look at line 17, page 7, the New Hampshire DDHS commissioner, as well as the deans of medical schools, it's plural, so it's not just asking Dartmouth to get involved. It could be University of Vermont, it could be the main DO school in Biddeford, it could be the 4 Boston medical schools. So it basically says the deans of medical schools and primary care directors to develop and implement educational methods with collaborative practice to facilitate the deputy physician medical knowledge and capabilities, which may lead to credit towards a future residency program. It's a little vague to me. So I feel, boy, I'm going to contact the people I know. I know the dean of the med school, who I spoke to this morning, and I contacted the head of the residency program in family practice in Concord. The family practice program in Concord has been around 25 years. The new one in Portsmouth, I think, is 3 or 4 years old, and we heard a little bit about potentially one in, that is a solution, creating more primary family practice doctors within the state, that's ended in the state. So I just assume the residency director at Concord, who I know very well. So I contacted him 2 days ago. Neither of them knew about this bill at all. They knew about the old one, and one of them had testified against it. But it surprised me a lot that the people who wrote up this bill didn't communicate with the residency director in the state or the medical school or the dean. So I don't think the homework was done. And the homework may be where the solution is. The dean's comment to me this morning was, I would really like to work with the state. He actually spoke to the governor. He talked to me about speaking to the governor recently in the last few months about trying to work on this problem because it's really a problem. And I think that's the way to go. I think is to engage the medical school, maybe with this new program up in Coos County, so that do we have people who can finish the residency program and complete the level 3. And the other part of this bill, in addition to creating a method of residency, talked about an alternative to step 3. There isn't one now. If you Google step 3 MLS, the medical license examination, there is testing out there that you can pay money for to prepare you for this test. But there isn't a separate test. There hasn't been a separate test since Florida 45, 50 years ago. The other thing I did other than operate and educate is I spent 17 years until 2019 as a member of the New Hampshire Board of Medicine in various capacities, member of the board, member of the medical subcommittee that doesn't exist as of this summer, and as a physician investigator. Dr. Conway will comment on that too. But if this goes ahead and you have deputy physicians out there with collaborative supervising people, there's going to be some mistakes out there, and those mistakes come to the Board of Medicine either as complaints or lawsuits. So the ultimate responsibility of making sure this is to the public is in the hands of the OPLC, which you know about, as well as the Board of Medicine. And you've got to get the Board of Medicine, particularly the physicians of the Board of Medicine, to sign on to this too. Because when bad things happen, it comes to that board, and that board has to figure out what to do. And I don't think they're interested in being a de facto residency program, nor should the state of New Hampshire. So that's it. Any questions? Yes, sir.
Representative Manjaputi?
Thank you, Madam Chair. Thank you for taking my question. I have very specific question in terms of when a medical student gets a residency outside of where they went to medical school. right?
Very common.
Very common.
More
which-
common than not.
More,
yeah.
yes. Have you know, or in your experience, do they stay back in the state that they did their residency because they have a choice, or do they go elsewhere?
So there's this thing called a match, which hasn't brought up, which is a computer. It wasn't computerized, but it existed in my day. So you want to go somewhere and you don't know whether that place is going to take you. I know in my case, I trained in Boston. I did my residency in Boston, and I stayed in New England eventually. You tend to hover near where you train. Training programs traditionally have often, when they finish a residency, tried to get their best and brightest and keep them there as future faculty. That's a small number. In primary care, where I trained at Dartmouth, I trained initially at Dartmouth and then in Boston, particularly this residency program that's been around 25 years, the emphasis has been to keep people here. And their track record is true. Concord Hospital currently has, I think, somewhere around close to 30 doctors in primary care who all trained in their own residency program. There are 3 members who trained in their residency program who've been president of the New Hampshire Medical Society. So they didn't leave New Hampshire. They didn't go up to the North Country, which is really what we want to do here, I think. But if you train them in the North Country, they may stay there. And I think that's the solution to this problem. You know, medical schools have actually expanded. To understand why there's 5,000 people who haven't matched, it's because there's more medical schools graduating people, and it hasn't kept up with the number of residency slots. Residency slots are very dependent on funding from the federal government. Medical schools, they get federal government through research grants and so forth, but Medicare and Medicaid payments to hospitals to train residents is significantly higher if you're training a critical number of residents, typically 20 or more. So I think we could increase the number of doctors training in the country if there was more federal funding for it, or interest in getting more federal funding going. That to me is also a solution, in addition to creating more residencies, which is what we need to do. But you've got to have federal support, which is usually connected to a hospital. So most residents train in a hospital. Even family practice residents at Concord spend almost half their time in Concord Hospital other than an office.
Okay. Representative Smith?
Any other questions?
Thank you, Madam
Thank you.
Chair.
I'm sorry I went so long.
One more
You have
question,
one
Doctor.
quick question from Representative Smith.
So, in typical residency, the resident physician is learning, is practicing, and so forth in the course of that thing, is working with patients, and how is that billed?
How's that billed?
Yeah.
It's billed entirely, not the work the resident does. He gets a salary, but it
Right.
isn't dependent on how much work he does.
Right.
Those people supervising him, the typical word is not collaborator, but attending. And there's a lot of them in an academic center. They're the ones submitting the bills of the work that gets done.
Because they've signed off, kind of like the pharmacist.
They are totally responsible. And during that time at the board, when you get a resident in New Hampshire gets a New Hampshire license, but it's a special resident license.
Right.
There's a little R next to it. Whenever they make a mistake or a problem and it comes to the Board of Medicine, we don't go after that resident. We'll interview the resident. We'll find out about the resident. We go after the attending.
Sure.
And that's kind of the responsible part. And I would hope the collaborators in this deputy plan understand that, because I think that's how the Board of Medicine would look at it.
Okay,
It's a
thank
huge
you.
responsibility. That's why I ended this discussion about responsibility at the Board of Medicine and the legislature.
Right. Thank you very much.
Thank you very much. David Conway?
Thank you, Madam Chairman, and other members of the committee. Oh,
Bring it closer.
is that better?
Yes, much,
Okay.
thank you.
I sent testimony to you electronically, which you should have. I also brought copies of it with me today, which I distributed. And I'll apologize for the fact that page 3 is really page 2.
All right, we'll approximate
Okay.
that one.
I am a retired OBGYN. I practiced, when I finished my residency, I practiced in a group practice in Portland, Maine. From there, I went to a rural area of Pennsylvania, which was underserved. So I know a little bit about staffing underserved communities. And I was there for about 8 years before I moved to Concord in 2001. And I was on the staff at the residency here in Concord. I worked with residents. I worked with medical students. I know what that's about. I know how medical school graduates end up with residency positions. I'd like to correct a couple of things that Representative Cole, said, that as far as the number of residency positions, in 2023, there were 40,375 positions total. Of those, only 2,685 were not filled in the first round of the match, which has been described to you. One of the alternatives to medical school graduates who don't match is what's called the Supplemental Offer and Acceptance Program, where they go into another list which is distributed to residencies that don't fill. And of those, only 227 were ultimately unmatched. So you're talking about only 227 medical school graduates that ultimately did not have a residency position after they graduated. One other correction I'd like to make is somebody who graduates from medical school is a doctor, period. That doctor cannot practice, cannot be licensed until they have received some kind of training. I testified against the earlier bills in 2018 and 2019, and the only thing that's changed in this bill is the title. It's a deputy physician instead of an assistant physician instead of a graduate physician. That my biggest objection has been the lack of supervision of the deputy physician, that the only thing that's required, there are two things that are required, that in the initial month, the deputy physician or the collaborating physician must be in close proximity in the same office to be available to the deputy physician. After that, the deputy physician has to submit 10% of his records every 2 weeks for the collaborating physician to review. That's retrospective care. That's the deputy physician is making decisions about care, but it's not being reviewed by the collaborating physician for 2 weeks. So who knows if he's making the right decisions? I don't have a whole lot more. I was not going to read the testimony that I gave to you. It tends to get tiresome after a while. One thing that this bill provides for is a track to getting a full medical license without ever having done a residency. That I will tell you that residencies in the first year here with this residency, every single patient that the resident saw had to be reviewed that day before the patient left to make sure that care was appropriate, that the diagnosis the residents came up with was accurate. That's not happening with the deputy physician. It's just not happening. Another correction as far as other deputy physician programs around the country, as of 2023, Missouri was the first one that was established in 2014. There are currently 8. I don't have the list here. but there are 8 other programs. And the intent of those programs is to not move towards full licensure after X number of years, but to move towards actually doing a residency where they had supervised training. What this bill is trying to do is to return us to the apprenticeship program, which was done away with in the late 1800s. And the outcome of that has been improved care, where there was very organized, specific training provided to those physicians. Representative Cole talked about shadowing physicians in residency. Shadowing means you follow around and you watch what a physician is doing. Not the case as a resident. That's what you do as a medical student. But as a resident, you're the first person who is seeing that patient to make some kind of decision, some kind of diagnosis, which you then take to the preceptor of the day, the person who you have to check out your impressions before that patient goes home. I don't have a whole lot more to say that's not in the testimony that I submitted, but I'd be glad to take any questions.
Thank you. Are there questions? Thank you very much for your testimony.
Okay.
Douglas Osterhout?
If it wasn't clear, I'm opposed to this bill.
Thank you, Doctor. It was quite clear.
Douglas Osterhout, OPLC. I should only take about a minute of your time. I was looking at the language, and it looks like some of the language as proposed is in conflict with RSA 310 and just sort of the roles and responsibilities. So if the committee or if the committee should decide to move forward with this bill, I'm just offering my services so we could amend that and make those two sort of align.
Okay, thank you very much for that. We'll let the subcommittee know that you can help. Questions? All right. Thank you very much. Well, if it's going to be amended, it's going to subcommittee. All right. Is there anyone else who wishes to testify on House Bill 1427? Sure.
This will be quick. It's in my written testimony as far as why don't medical school graduates match. And it's for a variety of reasons. There probably were about 7 reasons, anywhere from having low scores on the USMLE exams during residency, being not competitive at their first choice of residency, lack of appropriate backup or an alternative plan, not failure to follow guidance from the faculty advisor or dean's office, poor interviewing or interpersonal skills, did not rank enough programs, or failed the USMLE exam. So that's the pool of people you're looking at.
Thank you. That's pretty clear. All right. No one else is here on this. I'll close the hearing and open the hearing on House Bill 1394 and call Representative McGee. Well.
Thank you, Madam Chair McGuire. Good to be with you. Good to see you all again. I'm Representative Kat McGee, and I'm from Hillsborough 35, which is Hollis. I'm here to present HB 394, which is a bill that may be familiar to all of you. This bill came to us its first time 4 iterations ago when I was approached by a constituent of mine who is a music therapist in Hollis. about the issue of having certification under professional licensure in New Hampshire. And there have been subsequent hearings. I went and looked up the history. The original bill was HB 1286, which passed the House, but then was laid on the table in the Senate in June of 2020. It was removed from the table in September of 2020 and ITL'd. And then there was HB 209, which was a split vote on this committee and went to ITL. And then HB 532, this last year of this session, there was work and amendments on the larger bill and all appeared to be a go. And then it died on June 27th without all the signatures after a committee of conference. So there was a question whether we wanted to present the bill again, but in speaking again with the music therapists who've been participating in this process all along, nothing has changed for them. And I thought maybe what would be helpful is to sort of present to you the dilemma that they are confronting in their profession. So I went and looked up the Music Therapy Board certification website, has some information about where the profession is at with statewide certifications, and also why they're needed. So I just offer for you today this very brief blurb, which is that a national certification is not enough in most states, and this is a result of a policy shift over the past 10 to 15 years as the federal government has moved away from regulation or have been deregulating, and they've allocated that regulatory control to the state level. So in addition, many existing state regulations require that education and healthcare providers hold a state license. So that shifting landscape is the reason that they were brought forward to say, we really would like you to consider giving us the ability to be part of the allied healthcare under the state certification and licensure. So as a result, many current and potential clients are having difficulty accessing music therapy services within educational and healthcare facilities, which is where most of the consulting and work is provided. So that's sort of an access point. And then, of course, insurers don't have them listed in their drop-down menus for folks to choose in terms of a specific allied therapy, and the inability for people to choose them from that list also prohibits them from being reimbursed under insurance. So there are multiple issues in terms of them using their professional licenses here in the state of New Hampshire. So that's a little bit about the history. And then on the bill itself, as you all know, in last year's session, there were some changes to the OPLC statute, and some stuff was moved around. So OLS had a good time when I resubmitted the most recent amendment to them for reworking. And they have updated the bill that you have in front of you so that it is current with the OPLC statute as it stands today. And basically, it's giving the format to adding them into allied health professionals that they would require in statute, and has all of the changes that have been worked on and considered over the several years that they've been attempting to do this. So there are definitions here as to what music therapy entails, what it is, what it isn't, that it doesn't infringe in any other type of therapy that may be similar. I know the audio speech therapy folks had some concerns around language. They brought in language that have been used in other states. And there are currently about 36% of the states, so 18 states right now, have certified music therapy as an allied health in the state. So we're just trying to help these folks get where they need to be. And for those of you, I don't know how long all of you have been on the committee. I know some of you have been here the whole time. one of the things that was very interesting to me, because I knew very little about music therapy when I started this road with this constituent, in the very first hearing, she brought a former patient that she had worked with. And he is now an adult. He was a child when she met him. He was born blind, and he is now an inspirational speaker. And he was very inspirational the day that he came to the hearing. But what was amazing was that his parents were, they had a lot of difficulty trying to figure out how to reach him. So I liken it to sort of the miracle worker, right? You have to you have to figure out the right key in order to reach certain people. And once you do bridge that gap and do figure out how to reach those people, then you can have the kind of success that he had in his life. And he came into the hearing to give this committee that information. And I was really impressed. I didn't know he was coming, and I didn't, of course, know him. But I think since that time, the therapists themselves have come in on several occasions, both for work sessions and also to provide the committee with additional information. I think they're all sort of working today. And so when we talked about them coming, it was in the midst of the snowstorm. And I think they are very hopeful that, you know, there have been tears when the bill hasn't gone through before, but I think they're also, they're reluctant to hope at this point, but I am here to represent them and ask that you continue to give this your due consideration, because I understand that there may be sentiments against having lots of certifications or so many certifications or adding to certifications, but this is a legitimate form of therapy, and we have, you know, I have talked to people who have benefited from it, so that's how I've come to that conclusion. And I think that if we are not allowing them to participate with other forms of therapy, then we are, I think we're unduly picking those who can participate in insurance and those who can't. So, so I don't have any more information about the profession itself, and I think you have probably heard a significant amount of testimony on that on this committee. So if I can be of any assistance answering any questions, I will do my best to do that, and that'll just conclude my testimony.
Okay, are there questions? Yes, Representative Mangiapudi.
I'm sorry, Madam
Oh,
Chair.
fine.
Being a speech pathologist in my past life, and music therapy was a huge avenue for people with aphasia. One very well-known case is the Congresswoman Gabby Gifford. Her regaining of speech was through music therapy. And there are several instances where I've used that for people with autism to break through for communication. And this is only with people who are diagnosed with speech or communication disorder earlier. But music therapy can be very beneficial for umpteen other situations who are trained. So have you had opportunity to get those, when the music therapists, they're not just music teachers?
Oh,
Have you
right.
got input from music therapists, particularly on other than speech and communication disorder group that could benefit? Like one was the blind, or was the other ones?
Yeah, I think the overlap between speech therapy and music therapy has to do with communication issues in children and adults. And I think most people understand that music has a unique space in terms of how people connect to music. And in some cases, they connect to music and little else. But again, I'm not an expert. I didn't know that you were in speech therapy, so that's interesting. I do know that it is a therapy that in certain instances is unique in terms of how it can help someone overcome any number of disabilities, educational disabilities, learning disabilities, that kind of thing. So you're right. I think a lot of people conflate just being able to play music or participate in music. And I think part of that language is in the bill stating what music therapists do, how they collaborate, how they determine appropriate courses of care, and they document goals and they achieve those goals through the therapy. So like any other therapy. So that's
Thank
about
you.
all I can say.
All right. I think that's it.
Oh.
Okay. Representative Roy, Representative Schmidt.
Thank you, Madam Chair. Good afternoon.
Good afternoon.
So this bill that you're presenting to us today is the identical bill that has passed this committee in the most recent iteration, based on the collaboration with the speech pathologists and the agreement the two practices came to resolve the issue that did hang us up 3 or 4 years ago, right?
Yes,
So
that's correct.
this version is the one that was adopted by the House in the last go round, correct?
Yes, latest and greatest, all the bells and whistles.
Very
And
good.
also updated again for the OPLC changes, because I went back and forth with Patrick Conroy, I believe it is, in OLS.
Mhm.
He was very helpful in saying, well, this section's gone, so you can't refer to that. So, he updated it so that it is accurate, and it contains all of the work group product that this committee brought to the bill in its last iterations.
Follow up?
Follow up.
So as you know, I think she's not technically a constituent of mine in Dover because she lives in the South End and I represent the central area. But Marissa is her first name. I'm sure you've spoken with her many times. Do you know whether she's watching the hearing again today?
I would imagine she is if she's able.
Okay, perhaps we'll see that.
And I believe
online.
Representative Roy spoke with her this morning.
Well,
So she
then
was
he'll
cheering
speak-
us on.
He'll speak to that. I spoke with her relatively recently, and she's still very hopeful, I believe. So I guess Representative Roy will tell us. Thank you very much for your advocacy, and you can count on me to be voting yes on this bill. Thank you.
Thank you. You're welcome.
Thank you, Representative McGee.
Thank you.
Representative Roy.
Good afternoon. Thank you, Representative Terry Roy, Rockingham, District 31. I'm here as a co-sponsor today of this bill. As the previous speaker told you, I know this has been here several times. Like all of you, I wear a couple hats around here. One of them is the chairman of the Veterans Interest Caucus. And my interest in this bill is laser focused on veterans and what it can do for veterans. When I first heard about music therapy, I also, maybe like many of you, thought it was some kind of strange snake oil thing. When I heard music therapy, what the heck is that? So I did my research on it. The Department of Defense, and particularly the U.S. Army, has been using music therapy since 1945. It's a well-established thing. They sent out a technical bulletin in 1945 on the program for the use of reconditioning among service members convalescing in the Army hospitals. Since 2000, specifically around 2005, the VA has doubled the number of music therapists that work at the VA. So the Veterans Administration takes this therapy very seriously, and they use it a lot. The problem our constituents have in New Hampshire is that although we have a medical center in Manchester, it's not what's called in the VA parlance a full service medical. So they don't have all the type of things that you might find at a bigger VA hospital, to include music therapists. So veterans in New Hampshire who may benefit from this have to seek what's called community care. And to do that, they have to use a licensed music therapist, which we do not have in New Hampshire. Our veterans really can use this. And I, like many of you, am not a fan of just handing out licenses for everything that might possibly want or have a license. But this is an established, well-researched form of care for people that is not experimental. It's been used for many, many decades. And I feel that it justifies licensure so that these people can do this and provide this service for our veterans and get paid to do it. With regard to what music therapy does, I'm just going to read something real quick and then I'll conclude my testimony. Music therapy has been proven to help with a whole host of health problems. It can assist with physical rehabilitation, help people learn to speak again, improve communication skills, and help people manage negative emotions and combat depression and anxiety. All of these things that might benefit veterans. And I'm reading from a VA thing. When you listen to music, your ear collects sound waves and funnels them to your inner ear, where they are converted to electrical signals. Those electrical signals then travel through your brain, stimulating different parts of your brain to cause different reactions. Music stimulates the parts of your brain associated with memory, emotion, vocal imitation, and movement, among other things. As a result, music can affect the functioning of those parts of the brain on the body, meaning that it can have a real physiological effects. Since music stimulates the cerebrum, which is associated with memory, it can also help your memory keep it sharp, which may be useful for veterans struggling with brain injuries or PTSD-induced amnesia. While music stimulates the limbic system, which is responsible for emotional responses, it has also been shown to help suppress negative emotions while elevating positive ones. This can be incredibly useful in modulating feelings of depression and anxiety. The physical and cognitive benefits of music therapy are also manifold and always growing. Since music affects the parts of the brain responsible for the movement and communication, it can assist with physical or speech rehabilitation. Human beings have an impulse to move with rhythms, and when you pair listening to music with practicing a specific movement over and over, like clapping or taking a step, that movement can get more fluid and become ingrained in your muscle memory. Music therapists have been using this method to help chair-bound or bed-bound veterans get back on their feet for years. It is certainly useful for wounded veterans. Keeping in mind we're still fighting an epidemic of 22 veteran suicides a day in the United States, I would hope that the committee would take that into account and look at the possibility of using this to help our veterans in New Hampshire gain further access to that. And I'm willing to take any questions. Thank you for your time.
Thank you. Are there questions? Yes, thank you. I'm seeing someone else, give us someone else a chance first. Representative Mangiapudi.
Thank you, Madam Chair. So the Jamaica Plain or Roxbury VA Center has a very well-established music therapy, MIT, it's called Music Intonation Therapy. Have you been able to get that information very well formed? This was 1945. They've done a lot of study with the veterans. That has given a very credible thing with.
Yeah, they use it down there at the Jamaica Plain one. Unfortunately, that's quite a hike for a lot of our veterans, and they can't get down there. And there are a lot of people in places up here where they could get it if we could just get them licensed.
Sure, thank you.
Representative Gerhardt.
I just thought of something. Is there a remote option?
Sometimes not. It depends on the therapy, what they're being treated for. It's not always something you could do just over the internet because of the actual vibrations you feel from the music, even if you're using it to walk and things like that, to pick up motor skills. Perhaps, I'm not really sure, so I don't want to speculate, but everything I've seen is it's been in person. And there's also the issue of licensing across state lines and billing and things like that.
Thank you.
Okay. All right. Thank you very much, Representative Roy.
Thank you, Chairwoman, and thank you, members of the committee.
Douglas Osterhout.
Good afternoon, Douglas Osterhout, General Counsel, OPLC. My testimony is the same as last time. I found a couple of discrepancies between the language as proposed and the language in 310, and I'm just offering my services to clean that up should the committee decide to move forward.
Okay, so we should not move it forward without cleaning up the language. All right. Any other questions, comments? Thank you for.
Should we not consider the perfected bill and have the changes that Council Osterhout is referring to here in his remarks Shouldn't we have that done?
Yes, please. If you could send us where the issues are, we would appreciate that. Email works.
I can do that.
Yes. All right. Does anyone else wish to testify on House Bill 1394? Okay, I don't see anybody, so I'll close the public hearing. And I will see you all tomorrow.
Mr. Vice Chairman, I believe we have a subcommittee meeting tomorrow morning at 9 o'clock. Very good. Thank you.
Okay, guys. Oh.
Going to see Representative